of plenty of challenges, plenty of potential solutions and partners. How do we carve a unique space out for public health practitioners? What exactly should the Faculty of Public Health be doing to ensure that we are laser focused in ensuring that our advocacy is landing in the right way and having the impact it needs to have? And finally, where do we focus our efforts to ensure that in 1, 2, or 3 years' time, when we look back, we can hand on heart say, as a result of our individual and collective efforts as a faculty, we have made a difference. Now, this conference is one of a range of activities and interventions that you'll see from the faculty in the year ahead. Many of you are aware that ahead of last year's political party conferences, we were able to develop a briefing document on poverty, social exclusion, and economic disadvantage and disparities. That landed well with many of the political leaders we spoke to, and will be forming part of our platform as we prepare for the new and the next general election and the party conferences in the autumn. In addition to having an overarching narrative on the importance of poverty, economic disparities, we've also been doing specific work on tackling child food poverty, which is one, I think, of the greatest challenges that I think that we have as a nation, a challenge that is escalating, is happening on our watch, but it's also incredibly amenable to intervention, change, and improvement. So the faculty has also had a very strong narrative, strong advocacy actions on tackling child poverty. So within this, we are going to continue to strengthen our work in this space, but I recognize that this is not just the job of the faculty, and that actually what is powerful about what we have is that we have fantastic public health partners who are alongside us as we embark on this journey, and much of the work that we do is collaboratively. So I'm so pleased today that you'll be hearing from a number of colleagues who represent nationwide and national public health bodies, but also the Royal Society of Medicine, who's hosting us today. Now, before I hand over to my colleagues for their opening remarks, let me say a huge thanks, because events such as these do not pull themselves together. They're often colleagues who are working behind the scenes, organizations such as the RSM that have facilitated the venue, leaders that are coming together to commit to working together to tackle and address these issues, and our staff and colleagues who are working behind the scenes to ensure every detail that you'll experience today is done well and creates a memorable event. So I'd like to begin, before handing over to my co-chairs, with a huge thanks to everybody involved in organizing today. So with that, we're going to hear first from William Roberts, Chief Executive of the Royal Society of Public Health. Then we'll hear from Professor Jim McManus, President of the ADPH. And finally, Professor Maggie Ray, President of the Epidemiology and Public Health section of the RSN. William, over to you.
Thank you, Kevin. Thank you, everybody, for coming today. I guess I'd like to say 3 things as opening remarks to set the scene for today. The first is that whilst we might be living in a cost of living crisis, poverty and people struggling in the UK isn't a new thing. We could go back to any point in the last 1,000 years and see people who are poor suffering disproportionately from those who are not. And so I think to really focus our minds to think about the fact that this isn't just something that's happened in the last 12 months. This is something that's been happening for years, and this is a deep and entrenched challenge that we face as a society. The second thing I'd like to say is that we need to move beyond the idea of just restating the problem. So the first time in which people started to look at these issues probably goes back to the corn tax, which was probably the first time in which somebody actually really did something to close the inequalities gap in the UK. But also, this isn't just about us talking about what the problem might be, but also the solutions, both for the people in this room and those online. You will have brilliant solutions. And I'd like us to think collectively about how do we take those solutions and how do we actually implement them at a local level to make a difference in a collaborative way. And then finally, I'd like to just talk about the fact this isn't just about people in public health and the people in this room who I suspect all deeply care about the fact that inequalities really matter, but it's about the idea that we need to make public health everybody's responsibility. If you were to take any of 3 companies, Amazon, Apple or ExxonMobil, all 3 of those organisations have a higher turnover than the state of Belgium. So to understand that, their economic power is far greater than an entire country individually. Collectively, if you were to take the top 10 organisations in the world in terms of profit, they would be able to solve these problems overnight. So I ask us to think really carefully about how do we work collaboratively with those kinds of organisations to make a difference. I will hand over to my colleagues. Thank you.
Will has nicked everything I wanted to say, but that's not going to stop me. Colleagues, I think this event is important for a number of reasons, because it should enable us to do what we do as public health professionals, which is take the evidence, identify action, and then ensure that we coordinate and advocate for it. And the Local Government Association and the Association of Directors of Public Health produced our 11th annual joint report earlier this year on cost of living, and it's on the LGA website, and there is a hub of case studies on cost of living which I will talk to you about later. But I'm reminded, because we have Sir Michael here, that in 2014 the British Academy produced a report on 9 local actions to reduce health inequalities and poverty from a social sciences perspective, which Michael was instrumental in bringing about. And I say that because I was one of the people on the editorial board. And there are interventions in there. It was seen as a social sciences version of the Marmot Review, much under implemented, I think. And so today I have 3 asks of you, which is to think and discern today. Firstly, what can be done at national level that needs policy action? As we need to stop describing the problem and move to action, as we've all said. Secondly, what needs local policy action, like decisions for a local living wage that don't need government permission? And thirdly, what can we actually do? I'm conscious that yesterday we had the Great Volunteer Day. Occasional acts of charity are wonderful, but they don't bring about justice. Charity is only done because it seeks to bring about justice. So back to our values in public health. Poverty is important because we should care about justice. So consequently, what can we do today to bring justice closer to people who don't have it? That's what I'm looking forward to, and I'm looking forward to learning. And I wish you a wonderful day. And I'll hand over to Professor Maggie Rain.
Good morning, everyone. A great pleasure to be with you today. And I want to thank Kevin, William and Jim for getting us off to such an excellent start. And this is what we need, collaborative leadership. And I'm so proud that the major organisations working in public health in the UK and across the world have actually joined today to make today so special. We've got a fantastic audience here in the room, but we also have nearly 1,000 people online listening to this conference today. And as colleagues have said, it's now time to take action. As you can still tell from my Scottish accent, even though I've been exiled in England for nearly 40 years, I grew up with poverty. Poverty was an everyday fact in the communities that I worked with in Scotland. Things don't change. The poverty that we experience here in the UK is quite extraordinary. And of course, recent policies have plunged tens, hundreds of thousands more people into poverty. And I believe that that's a choice. And I believe that that choice can be remarkably changed if we all take the actions that are required at the national, regional and local level. And as colleagues have said this morning, this is where we have a fantastic opportunity to build momentum to realise that change for the populations that we serve. And so, as I say, it's a great pleasure to welcome you today with my colleagues, but also now to introduce our first and keynote speaker, Professor Sir Michael Marmont. Michael, we're incredibly grateful you've given up your time. You give up your time so relentlessly to pursue this agenda. I think you have got to be my public health hero of all time. And as I have mentioned before to many audiences, when I was leading on health inequalities in the Department of Health, it was Michael I turned to for help and expertise, and he gave so generously, so tirelessly to help pursue that agenda. We're all incredibly proud, Michael, of the work you do. You are truly an inspiration, and we can think of no one better to lead us in today's conference and actually to really signify the importance of today. You've given up your time to join us. Thank you so much.
I came just for the introduction. Brilliant introductions. And I will pick up those themes, the importance of national action outside the health sector, the importance of local action, not just diagnosing the problem, but taking action. Thank you. And the opposite of poverty is not wealth, it's justice. I'm going to do this. I start with this for a good reason. The opening line of my book, well, actually two reasons, my book, The Health Gap, was why treat people and send them back to the conditions that made them sick. Last week, The Guardian asked me to comment, the week before last, on Wes Streeting, the Shadow Secretary of State for Health, laid out his vision for the NHS, and The Guardian asked me to comment. He said, not funding, but reform. And my comment was twofold. It does need funding. It has been underfunded. That's what the figures show. But the kind of reform that I called for was not just, well, yes, we need to be able to see the GP more quickly, more community-based service, of course, but action on the social determinants of health. Wes Streeting wrote a letter to The Guardian saying he agrees with me completely, and then repeated the case for more GP services in the community. Well, good, that's not a bad thing. But what we laid out in my 2010 Marmot Review, the 2020, and subsequently, with these, firstly, 6 domains of action: give every child the best start in life, education and lifelong learning, employment and working conditions. Number 4, which is the topic of today, which is about poverty, but it relates to the others. They're interlinked. Number 5, healthy and sustainable communities in which to live and work. And the 6th was taking a social determinants approach to prevention behaviors. We've added 2, which really should have been there from the beginning. But the 7th was in the light of COVID, tackle racism, discrimination, and their outcomes. And the 8th one has really been there all the time, which is pursue environmental sustainability and health equity together. I guess the reason The Guardian didn't ask me to comment on the government's plans for health is because they've been a disaster and we need something different. I said in 2010, I'm very happy to work with the newly elected government. Regrettably, that feeling was not mutual. What happened was life expectancy was improving. About 1 year every 4 years. This graph starts at 1989. I could take it back to 1900, And you can see in 2010, there was a break in the curve. The rate of improvement slowed quite markedly. And then in 2020, there was an actual fall in life expectancy, a COVID effect. And it fell by more than 0.9 of a year for women and more than a year for men. And that was more marked in the UK than in most other countries. A slightly confusing graph, but let me explain it. This is healthy life expectancy in 2000 and healthy life expectancy in 2019. And the line shows that in general, countries that had better healthy life expectancy in 2000 had better healthy life expectancy in 2019. So there's Japan, was pretty good in 2000 and was pretty good in 2019. They improved. Above the line, Singapore, South Korea, Ireland, they improved more over that period from 2000 to 2019. And there's the UK below the line. Slower improvement, was pretty poor. We were pretty unhealthy in 2000. I began my Guardian piece by saying the UK is the sick man of Europe. That goes back to the 19th century. And there, happily, is the United States. I say happily, not for them, but there's always somebody worse than us. And it's usually the US. The regional differences are really interesting, and non-health people don't know this. I had dinner at the LSE on Thursday night. I was talking to Martin Wolf of the Financial Times, and he was completely unaware of this. So here's the social gradient in life expectancy for London and for the Northeast region. It looks rather similar for the Northwest. If you're in the least deprived, it doesn't much matter where you live. If you're rich, you can live anywhere, and life expectancy is pretty good. But then, the greater the deprivation, the greater the disadvantage of being in the Northeast. The consequences for life expectancy associated with deprivation are bigger in the Northeast than they are in London. The social gradient is steeper. So if you're deprived, it's worse to be in the North. If you're North, it's worse to be deprived. Then look at what happened over time. London, 2010-12, and the solid line is 2016-18, life expectancy improved across the gradient. In the Northeast, life expectancy declined for the poorest 10%, declined a little bit for the next decile, and then really did not improve for the bottom 6 deciles. Wow. This is where we were pre-pandemic. And to understand why is deprivation worse for your health in the Northeast and the Northwest than it is in London and the Southeast is of vital importance. So it's not just poverty, although that's billed as the issue today, it's the gradient, which, as I'll show you in a moment, gets us into the question of relative poverty and relates to, of all things I had to coin, a term no one can remember, proportionate universalism. But we did coin that term in the 2010 review because of the gradient. We were trying to combine the two ideas of typical Anglo-Saxon policy of focusing on the most deprived, the most needy, and a more Nordic approach of universalist social policies. So we said proportionate universalism. We could call it leveling up. That's the social gradient. If you focus only on the most deprived, you miss the health disadvantage from being relatively deprived, but above that threshold of intervention. So we said universal policies with effort proportionate to need. And what did we get post 2010? This is funding of local government, spending by local authority per person. The grey bars are total spending per person. In the least deprived quintile, the spending per person went down by 16%. And then the greater the deprivation, the greater the reduction. In the most deprived, it went down by 32%. What we've got here is effort inversely proportionate to need. The greater the deprivation, the greater the need, the greater the need, the greater the reduction in spending. If you want things that are reversible, policy actions that can be taken, here's one right there. Don't take money away from deprived communities. The current Prime Minister, you remember, he was filmed saying to the good burghers of Tunbridge Wells that Labour wanted to take money away from you and give it to poor places. We're not going to do that anymore. We're going to fund rich places like this. In thinking about the impact of poverty on health or relatively low income on health, I think we need to consider at least three issues. One, losses versus gains, relative versus absolute poverty, and the consequences for your health of being poor depend enormously on what's available. Healthcare is free at the point of use. A former health secretary had a brilliant new idea. Let's charge poor people for using the health service, he said. Brilliant idea. Let's charge kids for going to school. Wouldn't that be a good idea? We'll charge poor kids for going to primary school. I'd like to see public transport free at the point of use. If nutritious food was available at relatively low cost, rather than relatively high cost as it is now, then individual income would matter less. So all three are important. And let me talk about the losses versus gains. Danny Kahneman, won the Nobel Prize in economics, essentially said that the consequences for well-being of a delta decrement is twice the consequences for well-being of a delta improvement. In other words, if you boost universal credit by £20 a week, well, that's helpful. If you take £20 a week away, it's a disaster. And the consequences are twice as big in general from taking it away as giving it. So what's been happening on this losses versus gains? If we had considered, if we'd continued GDP per head at the same trend in 1990 to 2007, we'd be 30%, 33% richer than we are today. And do you remember, Andrew Marr was doing an interview with him and he said, now that you're a companion of honor, you're going to be rubbing shoulders with George Osborne. I'm not, thankfully. But what would you say to him? Well, I was on the radio, so I couldn't use Anglo-Saxon words. But you were boasting. We were the envy of the rich world. Our economy was doing better than everybody else. That's what you were telling us. And if you vote for Brexit, you'll no longer benefit from the economic miracle that we brought you. No wonder people didn't believe him. Look at this, the UK. We're the worst of all these countries. There's Italy, the US, France, Japan, Germany. So we got very much poorer than we would have been if we'd continued on that pre-1990, pre-2007 trend. And we're the only G7 economy not to have recovered to pre-pandemic levels of real GDP. This is fourth quartile of 2019 to the second quartile of 2022. We got poorer as a country and we failed to recover from COVID. And we're being lied to on a daily basis. I shouldn't get upset at being lied to, but how can we have a sensible debate if people won't tell the truth? And of course, there were distributional consequences from the Resolution Foundation, who do a brilliant job. Annual real growth in median equivalized disposable household income before housing costs. So for the poorest, this is 2718, big drop. Everybody got a bit poorer except the richest. 2018-19, the poorest got poorer. Then with the first year of the pandemic, hey, that was quite good for poor people. That actually showed that government policy could make a difference if they wanted to. But normal service has been resumed. And now we've gone back to making poor people poorer. That's the way we run our economy. That is changeable. That's not a given. And if public health wants to be serious in advocating, that is not a given. Public sector pay growth is lagging far behind private sector wages. In general, the public sector wages are higher because PhDs, people with professional degrees, civil servants, and so on. Whereas the private sector has a lot of low-paid cleaners and the like. But government policy, this is private sector increases, will increase the private sector more than the public sector. The pandemic went down, but normal service resumed. So when we look at pay settlements in the private sector, pay settlements in the end of 2022, early 23, essentially 1.9% down in real terms, and the public sector 6.1% down in real terms. So we want to persist with a low-paid economy. We want people to be relatively poor. And particularly if you're in the public sector, you should be punished for public service. And change in real income per capita between 2004 and 2019, there's London, which was rich to begin with. The rich get richer. That's the way it's supposed to be. And these other parts, but then these relatively poor regions got poorer. The West Midlands, North East, Wales, Yorkshire, and Humber, East Midlands got poorer. So if you're a poor region, you got poorer over that period. And then there's the issue of relative versus absolute poverty. Is it, I mean, you said the poor have always been with us, but not the way they are now. And, you know, I allow myself one Dickens a year, no more than that, because otherwise I spend all my time reading Dickens, watching BBC adaptations. So I allow myself one Dickens a year. But, you know, it's very different now. The ways of doing without now are very different from the ways of doing without that Dickens was writing about. And we see it, the infant mortality in the worst off is 5 per 1,000 live births. In Dickens' time, it was 250. So yes, absolute poverty's gone down, but as I'll show you, it's still playing a role. The sainted Amartya Sen said relative deprivation in the space of incomes with respect to income can yield absolute deprivation in the space of capabilities. Translating that, it's not just what you have, but what you can do with what you have that's important. If we look at relative poverty, this is children living in a household at less than 60% of the median income, so it's a relative measure. Before housing costs in 2010, 18% of children were growing up in poverty. After housing costs, that was 27%. And over the decade, the 27% went up to 30%. It went down marginally in the first year of the pandemic, showing you what happened to the poor, and went up to 31% after that. Is projected to go up to about 35% on current trends. What? More than a third of our children are growing up in relative poverty? Maybe that's an economic necessity. Well, it isn't actually. Child poverty at less than 60% median income for the OECD countries. There's the UK. We rank 31 out of 41 countries. I told you I'm pleased the US exists. They rank 38th out of 41 countries. They always look worse than us. But we could be like Iceland, the Czech Republic, Denmark, Finland, Korea, Slovenia. But we're not. We choose. I mean, the Americans are very happy to have their kids grow up in poverty and then shoot them when they go to school. The people of Iceland, Czech Republic, Denmark are really odd. They don't like their children to grow up in poverty. So they use the tax and benefit system to reduce child poverty. They use fiscal measures. And if we look at the proportion of non-housing household consumption spent on essentials by quintile, so essentials, food, fuel, clothing, and transport. In the richest quintile, between 2006 and 2019, it went up a little bit to about 43%. In the poorest quintile, it went up pretty dramatically to more like 59%. So you can see if prices go up, if inflation goes up, particularly for essentials like food and energy, wow, the bottom quintile are especially sensitive. And Colin, you talked about child food insecurity, food poverty. The Food Foundation's been tracking it. Something like 1 in 6 households experiencing food insecurity. And for children, it's 1 in 4. And then, of course, fuel. We published 1st of September last year. We said that without government intervention, something like 60% of families this winter just passed would be experiencing fuel poverty. Now, there was government intervention, but it was still dramatic. And that will, I was arguing with economists at the AFC and said, well, the evidence for social determinants of health is a bit weak. You know, we know that health determines income, but the other way. And I said, do you doubt that growing up in a cold home damages children's lungs? Have you looked at that literature and found it unconvincing? No, of course they haven't. They don't read the health literature. They just find it unconvincing because it's not done by economists. Growing up in cold homes damages children's health, their lungs, their mental health, their learning ability, and it's associated with excess winter mortality in adults. Fuel poverty, household income, current cost of energy, don't get me started on our bonkers energy market, and the energy efficiency of a home. But look at this, costs. If you're in the top 10% of income in France, you spend 6% of your income on energy, home heating. If you're in the top 10% in the UK, you spend about 6% of your income on heating. If you're in the bottom 10% in France, you spend 10% of your income on fuel. If you're in the bottom 10% in the UK, you spend nearly 18%. That gap between the rich and the poor is bigger in the UK than in any other European country. It's really pretty awful to be poor in Britain. And the US and the UK are the most unequal of the high-income countries. The Gini coefficient, told you I like the US, they're always worse than we are. US, the UK, Belgium, Sweden, Germany, France. And that really matters. I don't know if you picked this up, Burns Murdoch in the Financial Times. If you look at people in the top 10% of household income, adjusting for purchasing power, there's Switzerland, the US, Norway, the UK, and Slovenia. So where our top 10% are about as rich as the top 10% in Norway, poorer than Switzerland and the US. The median, the 50th centile, our median is quite a bit poorer than the median in Norway and the US, and certainly Switzerland. And the poorest, the bottom 10%, wow, we're a lot poorer than Norway, the US too. We're poorer, our bottom 10% is poorer than Slovenia. We are a poor country with some rich people. I've been repeating the nostrum that we're the 5th richest country on the planet. We're not. We're a poor country with some rich people. You want to do something about poverty and health? Do something about the nature of our economy. And then there's the funding of public services. Do you remember I dug in the archives, sort of ancient history, the Levelling Up white paper? Do you remember that? There was, in the white paper, they said that in Germany, they spent 2 trillion euros over 25 years to level up, to incorporate the former German Democratic Republic into the Federal Republic of Germany, which, by my calculation, is about 70 billion pounds a year. The budget in the white paper, the 4-year budget, was 4.8 billion for leveling up, 1.2 billion a year. Germany spent 70 billion a year to level up, and we're going to spend 1.2 billion. Has there been new money? I probably missed that in the budget, leveling up. IPPR North said the 2021 allocation of the Levelling Up Fund was £32 per person. But the drop in annual council service spending, those drops that I showed you, amounted to £413 per person. So we'll take £413 per person away, we'll give you £32 per person back, and we'll level up. Wow, isn't that magic? And public sector expenditure went down from 2010, 42% of GDP. It went down to 35% of GDP. Come back to that. And what we spend money on, I don't know what we're spending less money. We certainly don't spend it on children. Public spending on early child education and care, for the OECD countries, the average is $6,000 per child per year. In Norway, we've just done a report for the government of Norway. In Norway, they spend $12,000 per year. The average is $6,000. We spend $4,000. The US spends $3,000. We're not doing well. We're not spending on the next generation. Replacement rate of statutory sick pay or equivalent system for the first 4 weeks of sickness. In Austria, it's 100%. There's the UK. If you're sick, by God, you're going to suffer. We're going to make sure you don't have enough money to get healthy. And universal credit, the Joseph Rowntree Foundation and the Trussell Trust calculated the cost of essentials. And universal credit, that's the universal credit. That's the cost of essentials. And that's how much universal credit gives for a single person age 25 plus or under 25, or for a couple. So universal credit gives about 70% of what you need to cover essentials: food, clothing, housing, communications. And what about this one? You know about this one. Childcare costs, % of net household income. Italy, Britain, US, OECD average. In London, in inner London, you can pay £18,000 a year to have a child in care. My adult children say they know people who pay more than that, £18,000. In Sweden, the maximum you pay is 1,500 euros a year. One of the reasons we have poverty is that two parents can't go out to work. Or if you're a single parent, you certainly can't go out to work because you can't afford childcare. Look at Germany. And I wish politicians would stop saying we've got the highest tax rates for 70 years. We look at the numbers, for heaven's sake. And I've heard Conservatives, Labour repeat the same nonsense, absolute garbage. Here's the UK. This is from the Office of Budget Responsibility, the government's office. Look at the figures, for heaven's sake. So the various ways of calculating come out slightly different, OECD, the ONS, but on these figures, our tax rate is just under about 34% of GDP. The OECD average is about 36%. The G7 average is about 37%. The EU 14 is 40%. We are a low tax country. Stop telling us it's the highest tax rate for 70 years. I get asked, and as I say, I'm not a politician. I'd never win an election. I'd like us to be taxed at the average rate for European countries. Then we might have the services about the average for European countries, instead of limping along below the average in just about every domain I look at. And it didn't have to be this way. Again, this is from the Office of Budget Responsibility. Here's the UK and sort of ONS, OECD figures. They're slightly different figures. But back in the 1970s, we were a relatively high tax country. There's the EU 14. It went down dramatically during the Conservatives, came up a bit, but stayed at this relatively low level. There's other G7 countries, the EU 14. We are a low tax country. We could afford to do more. It's all pretty depressing. Why am I not depressed? I'm really excited. Coventry, a marmot city, build back fairer in Greater Manchester, altogether fairer in Cheshire and Merseyside, a hopeful future, Lancashire and Cumbria, Luton, a marmot town, Waltham Forest. Wow, 40 plus local authorities have declared themselves marmot places. I went to a rugby club where in Taunton, is that where? In the Southwest. Maggie is leading the charge on saying the Southwest should be a marmot region, of taking our 8 recommendations and saying, we'll do what we can locally to make a real difference. Let me finish with a quote from Raymond Williams. To be truly radical is to make hope possible rather than despair convincing.
So I think everyone, you'd agree, what a fantastic presentation, and absolutely brilliant to get us off to such an excellent start. Now, we do have some time, a few minutes for questions, if that's okay, Sir Michael. And I will keep an eye on the Slido online for anyone online who'd like actually like to ask a question. But here in the audience today, here those with us, we can start with some questions if we may. So can I go here first, please? Thank you.
Thank you, Michael. I have a question. In poverty in community choice at the national level, what language do we need to use, or what arguments do we need to make to persuade the national policymakers to make different choices? Or do we just give up on the national and focus on the regional and local and city level to make the kind of change that you want to see?
I'm sure that we should pay real attention to the local level of what one can do, but by no means do I think we should give up at the national level, because as I've been trying to show you, we've made economic choices that have meant that it's really bad for your health to be poor in Britain. It's worse for your health to be poor in Britain than in other European countries. And that means a change, a real change at the national level. And yes, we can decide what that means in practical policies, but it means a whole sea change. I mean, over the last 40 odd years, there's been a real shift in the proportion of national income that goes to the owners of capital as distinct from employed people. So the returns to capital have been greater. This is standard Piketty, that the returns you get from non-work are greater than the returns you get from work. And that's been a conscious choice by government. Paul Gersel wrote a history of the US. The rise and fall of the neoliberal order. He would claim that the neoliberal order has hit the buffers. It's really come to its end. So we had the New Deal order starting with Roosevelt in the US, 1933, and 1980 in the US, 1979 in Britain, ushered in the free market fundamentalism, the neoliberal order. And it's not working anymore. It's not delivering. You can see our economy is not growing. Our productivity is low. We've got more poor people. Health's not improving the way it should be. Health's getting worse for some people. It really isn't working. And I don't think we can give up and just say we need better local services. We need to be part, and our special point of view. I mean, I think about this all the time. I mentioned I was talking to Martin Wolf of the Financial Times. You know, he's just written a book about the problems of capitalism and democracy. He thinks they're both good things, capitalism and democracy, but they're in crisis and they need improvement. Well, we in public health are not experts in that, but we are experts in the health consequences of these political decisions. And that's how our voice needs to be heard. Put equity of health and well-being at the heart of all government policy. So we can't give up on the national. And who knows what will happen in national politics and elections, but we should be campaigning for the well-being of Britain. We need a complete change of approach. And that, notice I didn't say change of party. We need a change of approach.
Excellent, thank you. We now have a question from one of our members online, and this is about housing. And the question is, has the impact of poor housing been underestimated by policymakers?
I mean, firstly, well, let's take three issues with housing that are key. Thinking about fuel poverty and cold homes, the government stopped investing in home insulation after 2012. fell off a cliff. They were investing in home insulation, and they stopped doing it. Why would you want to help people? And now suddenly, oh my gosh, we've got poorly insulated houses. It costs a lot to heat them. So, well, they did a lot of short-sighted things. And that's terrible. So the thermal property of housing, we've got among the worst housing stock in Europe. Several years ago, there was an interesting study of indoor temperatures in Edinburgh and Stockholm. The outdoor temperatures are much lower in Sweden than they are in Scotland, but the indoor temperatures in Stockholm were 6 degrees higher than in Edinburgh. And they pay less for the heating because we've got such poor quality housing. So the quality of, and in general, the quality of housing is worse in the private rental sector than it is in social housing. So the second is the cost. Housing is unaffordable. I wandered into the Lion's Den and had dinner with some housing developers and said, you guys, what you think is affordable housing is not affordable housing. You're just pricing housing out of reach of ordinary people. If you're a young person in London, and we know what's happened, that home ownership has gone down dramatically for young people. And with the decline of social housing, there's been a rise in the private rental sector, and it's unaffordable. The reason I showed you national figures, child poverty back in 2010 was 18% before housing costs, 27% after housing costs. In London, it was something like 17% child poverty before housing costs, 37% after housing costs. So the second is absolutely unaffordable. And related to that, the third issue is we stopped building. Margaret Thatcher, in her infinite wisdom, said, sell off all the housing stock and you may not build another single dwelling to replace it. So guess what? Got a housing shortage. And then, of course, you know, the politics of not in my backyard, where no housing here, we don't want it. So it's a big political issue, but all three of those are key.
Thank you. Thank you so much. I'll now go to Selina.
Thank you for such a wide-ranging and, but anyway, interesting talk. The issue about local action and the Marmot towns, is there evidence yet that they're making a difference? Because I think I've heard something about life expectancy in Manchester, wasn't it? And shows positive changes. So I just wondered if you comment on the balance between, you know, what you can do locally in terms of effectiveness and national policy.
Yeah, it's an excellent question. Is there evidence that that local action makes a difference? Yeah, I saw that paper, Manchester, wasn't very convincing. I'd like it to be true that the life expectancy improved, but it wasn't very convincing. It was, you know, in Coventry, which was the first one, they're now trying to do a proper evaluation, but we got involved with them a little bit. And it's not pucker research. There's no real comparison group. So I'm a bit shy about saying too much. But what we did see was the proportion of children age 5 with a good level of development went up. The proportion of 18 to 24-year-olds not in employment, education, or training went down. The proportion of people in work earning a real living wage went up. So we can't say it was a direct result of Coventry being a Marmot city, but at least the indicators were moving in the right direction. And one of the things we've done with each of these city regions in which we've been working is to try and ensure that they have a monitoring framework so we can answer your question.
Excellent, thank you. And I'm afraid now our last question, again from one of our listeners online, it's about your opinion on is there a difference between each generation, intergenerational effects, particularly thinking about people that grew up in austerity in the past to now the younger generation today?
Well, the promise we'd like to give to the next generation is things will be better for you than they were for the current generation. So two things. One is Gallup organization does surveys and asks people, do you think that the future will be better for today's children than it was for you? The majority of people say it'll be worse all across Europe. We've ruined it, people are saying. We've made it worse for our children. That's partly climate change, but it's also conditions. Another way of looking at this is social mobility. And economists have various ways of describing it. But what's the correlation between parents' income and the income of their adult children? And one way of looking at it is that how long would it take if you were in the bottom 10% of income now? How long would it take to get up to the middle, the median? In Denmark, it would take 2 generations at the current rate of social mobility for the bottom 10% to get to the median. In Norway, Sweden, and Finland, it would take 3 generations. In the UK and the United States, it would take 5 generations. In Brazil, it would take 9 generations. Why this big difference? Because the magnitude of inequality correlates very highly with social mobility. The greater the distance between the rungs of the ladder, the more difficult it is to get from one rung to the next. And investment in early childhood. You could be like Norway and invest $12,000 per child per year, child age 0 to 5. You could be like the OECD average and invest 6,000, or you could be like us and invest 4,000. And we are heading towards Brazil. We're not heading towards Norway or Denmark. We're heading in the wrong direction. So to come back to Matilda's question, we can't ignore national policy. Do we really want to say we'd like it to be like Brazil, where today's children have got no chance at all of getting up to the middle if they're poor? Or do we want it to be more like Denmark or Norway, where, hey, you know, it'll take a bit, but they'll get there. So the intergenerational equity is absolutely crucial.
Thank you so much. Can we please show our appreciation for Excellent. So also colleagues, I'm really delighted that William, Jim and Kevin did such fantastic introductions. Can we thank them for their contributions? Thank you. And I'd now like to hand over to Professor Paul Roderick, who's going to chair the next session, please. Thank you, Paul.
Thank you, everybody. Thank you, Maggie. It's a great pleasure to be here. It's my first face-to-face meeting for 4 years. I'm a retired academic, so I'm a bit out of practice, but I'm chairman of the faculty's Poverty SIG. I know many members are here and online. If you want to join, please join us in pushing the faculty's agenda. What a tough act to follow. What a fantastic opening talk, Sir Michael. So inspirational and dissecting the problem of our injustices, but giving us some hope for the future. So this session is 5 short talks, giving different perspectives on poverty and the cost of living impacts and responses from around the UK, a mix of online and face-to-face. So each talk will be about 9 minutes to leave a little bit of time for questions after each speaker rather than as a panel. And I'll try and get people to speak to time with a 1 minute warning.
And so let's move straight on. And sorry, I should say, if you're virtual and want to ask a question, please put it on the QA function as the last session. So we'll move straight on to the first speaker, Jerry McCartney. Jerry trained in primary care and public health and has a degree in economics and development. Headed the Scottish Public Health Observatory from 2010, and since 2021 has been the Professor of Wellbeing Economy in Glasgow. So who better tell us about the impact of austerity and the cost of living crisis on health inequities in Scotland? Over to you, Jerry.
Well, please don't clap. I've only got 9 minutes. Okay. So thank you for that welcome. I'm going to tell you what I'm going to say, then say it, and then tell you again in the traditional way. So as Michael has very eloquently talked about, the rate of improvement in life expectancy in the UK has slowed markedly. It's not unique to the UK. It's happened in many high-income countries since around 2012, i.e. well before COVID. That's really important. For people living in the most deprived areas, however, life expectancy has been declining throughout that time period. So we've got a really, really massive problem here. I'm going to rehearse very, very quickly that there's very good evidence now that economic policy and particular forms of austerity, as we've seen implemented across the UK, are responsible for these stall trends. And these, in turn, have been exacerbated by the direct and indirect impacts of COVID-19, and now, of course, by the cost of living crisis and inflation. So I'm going to quickly rehearse all of that. But I want to finish, I guess, the whole presentation and put this in your mind from the start, that I think the public health voice, in particular, the national public health agencies, of which I was a member for many years, has been quite muted on this for many, many years. And I think we now should be standing tall on the back of the research that Michael's articulated and the research that I'm going to talk about today, and make our voice heard, because this is not well known in economic circles, and it's not well known in policy circles. So, as Michael's shown, this is what should have happened to life expectancy in the UK for females on the left and males on the right. This is what actually happened in the years between 2012 and 2018. So we saw barely any improvement in life expectancy whatsoever, leaving us well behind where we should otherwise have been. That's the average trends. If we show the inequalities in trends, as illustrated by dividing the population into 5 groups. So this is Scotland's mortality rate, so low is good in this graph, going all the way back to 1981. Again, pre-pandemic trends here. You can see that life expectancy had been improving till around 2012, levels off. But for the most deprived fifth of the population in Scotland, things get worse in absolute terms, while they still continue to get slightly better for the most affluent groups. That's true in Scotland. It's also true in England. So things are getting worse for our poorest communities. Life expectancy is going down, mortality is going up. We published this report last year, which looks at all of the causes of these stall trends, published by the Glasgow Centre for Population Health and the university. Note that the national public health agencies wouldn't put their name to it. The reason for that is because of political pressure and the pressure that national public health agencies feel about articulating the political causes of these stall trends. And what we showed is that austerity implemented across many countries after around 2010 is the key driver of this, but also there's a contribution from historical increases in obesity that we saw in the decades up to 2010. And that's the main causes, the main drivers of the stalled trends. Is there evidence to support this? You should be asking. Well, yes, of course. There's a huge political, there's a huge literature on political determinants of health and how that leads to health consequences. But we've also got a mass now of international evidence of the impact of austerity policies in general. So we see that in Germany, we see that across European countries, and we see that from a panel study by Veronica Toffoluti and Mark Suchra. We see it from a paper by Lewis Rajmal et al., looking at a more recent time period. And then we summarised that with a huge panel study looking at 4 different measures of austerity over a long time period, with adjustments for various other confounders, various forms of adjustment to isolate the austerity impact. And the austerity impact is large and it's consistent across countries, especially when austerity is implemented during periods of economic downturn. And as Michael's illustrated, that's pretty much what we've seen constantly since 2010. What's more, we now have a wealth of evidence in the UK of the particular type of austerity that we've implemented here, because austerity can take different forms. So we see it in relation to sanctions policy and food banks. Lots of work on food banks being done in the UK. We see it in relation to homelessness, a key pathway. And we see it in relation to welfare reform. We saw a lot of increased conditionality in sanction policy in the UK since 2010. Sadly, that's been reiterated again since the pandemic. Quite difficult to get good data on this. So a lot of these studies use Understanding Society because the DWP still refuses us to link the data on benefit sanctions and health outcomes. We've got studies on the rapid rise in elderly mortality across England and Wales. We've got good studies again on disability-related budget reductions. So again, different forms of austerity. We've got modelling studies, we've got studies looking at local government funding, all of which have been pointing in the same direction, that austerity, particularly the form implemented in the UK, has been damaging. And then, of course, comes along COVID-19. As I've said, these trends predate COVID-19, but these have exacerbated it and exacerbated the scale of inequalities in particular. Just taking some data from Glasgow here, we see that the rate of COVID, direct COVID deaths here is about double in the most deprived fifth of the population compared to the least deprived fifth. So all of those pre-existing stall trends and inequality trends are just massively made worse by the COVID pandemic. But not just the direct impacts of COVID, but also the indirect impacts, as I'll talk about in a second. It's also worth mentioning that although the impact of COVID has been large, it's nowhere near as large as the ongoing impact of health inequalities in the UK. We calibrated the predicted deaths from COVID-19 at the very start of the pandemic against the years of life lost over time from health inequalities. And it's about 6 completely unmitigated COVID-19 pandemics every 10 years due to health inequalities. So the scale of health inequalities is an ongoing bigger challenge than COVID-19 will ever be. Of course, we've also got all the indirect impacts, so the unmet need for healthcare as people postponed or couldn't get access to the healthcare they needed, but also the economic and social consequences of the infection control measures, which were very necessary. I'm not arguing against them, but these also had unintended consequences on health, something we published in the DMJ through all of these different pathways about social isolation, about employment loss, and so on. And then, of course, following COVID-19, we see the impacts of inflation. So we've got a preprint up now on this model. So we used an existing policy simulation tool in Scotland that we actually modelled on the old London Health Observatory tool. And this was used to estimate the impacts of inflation on mortality in Scotland. And I'll show you the graph in a second, but the estimated impacts are very, very large, even when mitigated by the mitigations put in place by the UK government last autumn. So these were put in place to mitigate the high price of gas and electricity and to reduce the cost of living. So when we modelled this, you can see that the percentage loss in, or the percentage change in premature mortality in a fully unmitigated scenario was huge in the most deprived. So we're suggesting an up to 23% rise in mortality in an unmitigated scenario in the most deprived group. Of course, the mitigated scenarios fortunately brought that right down, but still 8% in the most deprived groups. And that leaves a 6% predicted rise in mortality for the total population in the mitigated scenario. And that's kind of what we're seeing. So there's been a lot of anxiety in the academic journals about what we're seeing called excess mortality following COVID. So it's not direct COVID-related deaths, it's happening across cardiovascular disease, it's happening across cancer, it's happening across a whole range of different causes. And what's absent from that debate at the moment is the role of economic factors. So we're seeing a lot of debate about the role of secondary prevention, about getting people back on statins and their antihypertensives. Important that that is, we need to start talking about the economic consequences. So to conclude, and with my 1 minute sign being waved at me, the current higher than expected mortality rates across the UK should be explained by the ongoing impacts of austerity that have not left us and have impacted on trends since around 2012, the direct and indirect impacts of COVID-19, again, which are still hanging over us, and then the impacts of inflation on real household incomes, especially in the lowest income groups. The calls for improved uptake of secondary prevention, most recently by our chief medical officers, is important, but it's a severely inadequate response to the current mortality trends, and it's an insufficient explanation to what's happening. The links to the recent reports are all there. I have no interest at the close, and I'd like to thank all my co-authors. Thank you very much. Sorry, we have questions? All right.
Thank you, Joe. Brilliant. And thank you for keeping us time. Brilliant analysis. So open to questions from the audience. To Jerry, you have a few minutes. Anyone has any questions? Yeah, William.
So I'm going to indulge myself here. I loved your description of the impact of austerity compared to 6 COVID pandemics every 10 years. Do you think we're just not very good at explaining the reality of these things, people? That really struck me. And I often think there's lots and lots of papers that say this is the case, but that's probably the most arresting thing I've heard in some time. And I wonder if you think we have a problem with communication rather than a problem with evidence.
It's a really good point, and it's worth saying that maybe I've not communicated it properly though, because it was 6 fully unmitigated ones. So if you remember the initial graphs that were showed where we did nothing about lockdown, nothing about closure, it was 6 of those every 10 years from health inequalities. So there are problems when we try and do that very shorthand thing. I once produced a graph again based on some work that the London Health Observatory did, which took the Glasgow subway map and put on a life expectancy figure for different ends of that subway map and showed a massive life expectancy difference. And that gets quoted all the time. But in Bridgeton, which was the area with the really low life expectancy, people got really upset about that because it stigmatized their area. So we do have to be careful. Obviously, I wasn't trying to stigmatize that area, but there are unintended consequences, I think, sometimes of using these shorthands. But I generally agree that we should be trying to find really quick and easy ways of understanding the trends that we've seen.
Nicholas Dingley, RSM, fantastic presentations. To pick up on your point and looking at the Slido questions, a lot of people are saying, is there something wrong with the kind of our political debate discussion and the involvement of the general public, and what can we do? And I think this ties in very well with the Michael Marmot's points. That's a big problem, somehow the quality of our politics and how we interact with politicians, and what can we do to improve, to make sure the facts are known and that the politicians are reached and they stop lying to us.
Yeah, it's almost as if most of the media are owned by billionaire barons that stop us getting these kind of stories out.
We better move on. Jerry, thanks so much. So, moving swiftly on, our next talk is from Helena Robinson, which is going to be online. I hope we can link in. Helena's very experienced in local government. In local government at senior level. Helena has worked as head of health improvement in Swindon alongside Steve Madden, DPH. She's been running Live Well Swindon and has been in charge of their response to COVID and now cost of living. So really well placed to tell us about our local authorities' response to the current crisis. So over to you, Helena. Thanks.
Thank you very much. Can you hear me and see the screen okay?
Yeah.
Great, thank you. Okay, so thank you very much for having me today. My name is Helena Robinson, and as Paul said, I'm Head of Health Improvement Services at Swindon Borough Council in the Public Health Department. So I'm with you today to run through some of the work that we've been doing as a local authority in response to the cost of living crisis. I'll do a very quick overview of Swindon the Place to give you some context before I gallop through some of the action. So if our DPH, Professor Steve Madden, was with you today, he would describe Swindon as a northern town that is slid south, given our demographics. He would also say that Swindon is a medium-sized town, small enough to wrap your arms around, but complex enough to make us interesting. And I'd have to agree with that. So a couple of headlines from this slide. Swindon's population, Swindon's population is around 222,000, but more likely 230,000 based on our new census. We are a town that continues to expand with an average age of 39 years. We have good life expectancy. However, our healthy life expectancy shows that people in Swindon can be living for about 20 years in poor health, and that's not good enough. We have around 11% of our population from a non-white heritage and over 40 languages spoken across the town. Swindon is generally economically prosperous. This slide shows that although we are not the most deprived compared to other local authorities, we do have pockets of deprivation that sit in the 10% most deprived in England. Citizens Advice Swindon ran a resident survey in June 2022 in order to get an understanding of the extent of the crisis locally. A repeated survey in March showed continued and increased challenges for the people of Swindon. More than 1 in 4 people have had to skip meals to save money, which is up from 1 in 5 in the June survey. 1 in 2 people said their mental health had been negatively affected by the cost of living rises. 41% of people said their physical health had been negatively affected by the cost of living rises, up from 34%. 1 in 5 people have reduced spending on healthcare. 1 in 10 people had visited a food bank, and this has doubled since June 2022. More than 1 in 5 people said they did not have enough money to meet essential costs. More than 1 in 4 have had to borrow money or use credit to pay for essentials. More than 7 in 10 have said they have not switched on their heating to save money. And nearly 50% of people have used savings to meet everyday costs, with 1 in 5 saying they've had no savings at all. So it's important for us as a local authority to use insight and intelligence such as this at a local level in order for us to best plan our approach and to ensure that the action that we take is based on local evidence and local need. So what has Swindon's response been? Swindon Borough Council, as a small local authority, often means that public health are called upon to respond swiftly to both local and national challenges, the cost of living being a good example. Public health are providing strategic leadership to a situation that cuts across wider determinants of health and touches all aspects of council delivery. So it was important to us that we set up a robust mechanism to bring together intelligence, insight, ideas and solutions to address the cost of living on behalf of Swindon population. It was acknowledged that many parts of the organisation would be looking to address the issues through their own lens, but we wanted to ensure we could achieve a collective and collaborative response, maximising opportunities and funding and avoiding duplication of effort, which can often happen when things arrive and move at pace. So to this end, we set up a strategic cost of living group open to all council departments, but most importantly, social care, housing, education, revenue and BENS. The strategic group provides the link between service delivery and the corporate governance structure, both at officer and member level. We also have a separate workforce task group to bring what workers are seeing and hearing on the ground back to the group to influence action. As well as the internal strategic group, we have established a partnership group so we understand the challenges, the demands and the response across the whole system. The partnership includes stakeholders such as police, fire, health, voluntary community sector, faith leaders and business. This partnership also links across the integrated care system. We have created an internal cross-council action plan called Keeping on Track, which is a nod to our railway heritage. There are 5 overarching core themes, which can be shown on the slide, but cover reducing inequality, building local capacity, community engagement, governance and funding, and workforce. So some key headlines of our achievements to date. Since mid-November, 905 grants have been issued to households through our discretionary application process through the Household Support Fund. We give between £100 and £200 of supermarket or post office vouchers. We distribute grants through our Emergency Assistance Fund at the rate of about 50 applications per month, and this is rising monthly. 26,000 vouchers for school children in receipt of free school meals have been distributed. This is equal to 9,000 households supported during school holidays and the equivalent to £550,000. Over £140,000 has been distributed to our local voluntary and community sector partners to deliver local projects. Citizens Advice Swindon have been funded to deliver financial first aid, and an estimated £281,000 of unclaimed benefits have been realised to date. We have been expanding our local hero volunteer programme, which in just 1 month saw 210 hours gifted in support of residents who would otherwise not have any other means of support. And examples such as knitting blankets, making draft excluders, offering practical assistance with tasks and befriending. We've established a Feeding Swindon partnership, which is part of the Feeding Britain network, and have 69 organisations and 28 council teams contributing regularly and driving forward actions such as affordable schools and cost of living roadshows. Swindon Borough Council has a Live Well hub, which is a point of contact for information, advice and guidance for all things health and wellbeing. We issue food bank vouchers, administer the discretionary grant, run a free shop with clothes, toiletries and non-perishable foods. And most importantly, we're there to listen. We have rolled out 40 warm and welcome spaces across Swindon, which act as a place of connection, resources and advice. We support groups with a small thank you donation to help with starting up, staying open and providing refreshments. Places include libraries, church halls, community centres, and we even have a funeral directors on the list. As the weather warms up, these spaces will remain open as welcome spaces and will become cool spaces if temperatures soar. Swindon Borough Council have also produced 19 top tips, which are available on our website and through a QR code. This brings together multiple resources, guides and advice so people can access information all in one place. The orange box shows the extent to which we have reached people, with Facebook being a clear winner. But we mustn't forget that many of our Swindon Borough Council employees are also Swindon residents too. And so we have produced promotional materials linked to the 19 top tips and workshops for employees to support them through the crisis and support them when working with local residents. But as you all know, we are not out of the crisis yet, and we anticipate our coordination of this work will continue for very least 18 months, and our plans reflect this. We will be using health inequalities funding from the Integrated Care Board, as well as some of the shared prosperity funding awarded to Swindon to extend our officer involvement and further develop sustainable and effective projects at local level. We will continue to work at pace, talking and working alongside our communities and partners to ensure we have a joined up approach, placing residents at the heart of decisions and ensuring individuals and families are not alone. If people are interested to know more about what Swindon has been doing, Swindon is a case study in this year's LGA and Association of Directors of Public Health's annual report, with an interview with Professor Steve Madden, our DPH, and Councillor David Renard. Thank you very much.
So Helen, sorry for your very diverse responses and elucidating them so well. So time for a couple of questions from the audience. Do you have any? Sorry, yeah. Okay. Yeah.
So, Ellen, my question is, all those achievements are remarkable, but they are sad because we shouldn't need them, right? If things were correct, then these structural inequalities wouldn't exist, and we would be here looking at health improvement of plugging the gaps that are left by bad central policy. And my question is, how much of what you have done is going to stay, and how much of it is like surge response that will be scaled down afterwards? Because that's the problem. That's what the Sir Michael showed, that if you increase £20 the universal rate is great, if you reduce it, it's a disaster. So how much, and this thing of giving and taking back is really bad for people as well. So yeah, that's what I wanted to say. Thank you.
Yeah, I mean, I think that's an excellent point, and something that we kind of always wrestle with when we're trying to develop and work within communities. I think we are very acutely aware of that. Some of the funding that we have been given through central government, we know is on a time frame. So we do try and ensure that we don't kind of create something that once taken away has a worse effect. I think what we're trying to do with our voluntary and community sector is work really hard to make sure that whatever is put in place, we look at how that is sustained and that we don't create that dependency, because this is about giving people choice, but also control, so their own ability to manage their own lives and their own decisions. And it's about us kind of building that capacity locally through sort of individual information, advice and guidance, but also building the capacity of a network of connections that sort of are beyond the house, beyond the garden gate and beyond other networks, so that people do have that sense of resilience and that sense of ability to take control of some of the decisions they need to make.
Thank you very much, Helena. I think we'll have time to move on now. So thank you very much. And we'll move on to Catherine Parker, Catherine, who's very experienced consultant in public health with a major interest in public mental health. And she's working for an NH Trust in Teesside and going to tell us about their approaches to the CAM service and financial barriers. So over to you, Catherine.
Very much. So I'm here excuse me, very much representing a partnership between TZESC and Wear Valleys, which is a specialist mental health, learning disability and autism trust, which covers part of the North East and North Yorkshire, and our partners in Children's North East. And just to give a little bit of wider organisational context to this piece of work, we're currently on a significant journey to change as an organisation, and as part of that have made a number of commitments in terms of addressing health inequalities, and one of those most pertinent commitments is around poverty. And that's for a number of reasons, really. It is about the disproportionate impact that poverty has on people who access our services. It's about the recognition that poverty can really paralyse an individual's journey to recovery. And it's obviously about the growing and deepening problem of poverty that we've seen expanding as the cost of living crisis has expanded within our communities. It's really, we wanted to acknowledge really that this is an issue that can really leave our staff feeling very overwhelmed, both in terms of the scale of poverty that they see on a day-to-day basis, but also the impact it has on people who use our services. And that can leave our staff feeling really helpless. Oh, it's not on my screen here, so I'm not sure if I can turn it off at this end. Thank you. Yeah, it can leave staff feeling really helpless, partly because of everything we've heard about what needs to happen at a national level. And also that, you know, the questions around, is this our core business as a specialist health service provider? So working with Children's North East, poverty proofing really gave us the opportunity to take a structured approach to understand and articulate what we're uniquely placed to do well as a specialist mental health trust. So this is what we did. We reached out to our partners at our local Office for Health Improvement and Disparities and to Children's North East. And we knew Children's North East had about 10 years worth of experience in poverty proofing the school day. And we really wanted to understand how we might learn from that and apply it in a healthcare setting. And we reached out at a very fortuitous time because their response was, we've just been funded to translate that learning into healthcare settings, and would you like to be one of our partners? So we jumped at the chance, and it gave us the opportunity to really bring in that independent external expertise into the organisation. And Children's North East spent 6 months with us, and this is what they did. Really rooted in those principles that poverty is a structural inequality and that the centrality of lived experience voice must come first. They trained our staff, they scoped our services, and they consulted with families and carers and individuals who were using our child and adolescent mental health services in South Tees, and they reported back to us. This is what they found. So lots of good stuff. People were really welcomed the fact that we provided things like free parking and like taxis. And crucially, when people were asked about their financial situation, they had a positive experience of that interaction with our clinicians, but it didn't always happen consistently. And there was a huge amount to learn. So we know that people are missing healthcare appointments because they can't afford to reach them. So this was a carer. She missed loads of appointments, not because she wants to, because she really, really can't afford to take him all the way up there. And we know that as well as missing appointments when people attend, they're often prioritising that mental health appointment over something else. So they might be missing out on treats, special food, trips out with the family in order to access NHS care. We're also not always aware of the impact of things like opt-in policies in our organisation. So this has come from one of our staff members. Every now and again, we have a family who can't answer a call because they don't have credit on their phone or they don't have a phone, and they end up getting discharged because we send them a letter to say they need to call in, but they don't have a phone or they don't have credit in order to do it. So thinking really carefully about things like, are we creating an additional structural inequality there by the way that we design our access to our services? And people told us having a broad range of ways to access the service would be really helpful. And in particular, things like email were actually much better than texts because people can go into a town centre and access free Wi-Fi, whereas if they've got no credit, sometimes they can't even read the text. Our reimbursement policy for expenses wasn't always well understood or followed. And sometimes even when it was followed, there were practical hiccups. So there was a lady who told us about the person who had the keys to the petty cash wasn't there on the day that they attended. So they'd done all of the bits and pieces, but that £7 that they were due to get for their taxi that day, they didn't receive. That might have been £7 that they were going to put on their electricity meter or buy food for the week. And something like that could really put somebody off attending an appointment in future if they think there's a risk of them not being reimbursed in real time. There were also concerns around some costs associated with the way that we deliver care and treatment. So there was a really brilliant parent-led CBT book, which people loved, but it cost between £7 and £12. We're now providing that for people because some people found it difficult to access. But also when we're asking people to do things like behavioural activation activities, we might tell families to go and have a board games night or get the bus into town. Often these things come with a cost. So it's about us being really mindful of those costs and making sure that we're not creating barriers right down to if we're asking someone, for example, to take a mood diary, not assuming that they've got access to a pen and paper in the household. It isn't always the case. There were some great examples, though, of where professional curiosity made a real difference. So this was from one of our clinicians. It was only when we thought to dig a bit deeper that they told us. It would have been easy to think they're just not bothering, but actually when we asked, it was because of the costs. So we know that poverty is really exhausting. So the day-to-day grind of living in poverty and getting from one day to the next can consume people's bandwidth. And unfortunately, navigating NHS services sometimes requires a huge amount of tenacity and energy. And it's energy that people might just not have if they're in that circumstance. So one of our families told us a barrier in the first place is having to get them referred in. I don't actually know what's available and I've got to get them referred in. What made a difference was planning, so people felt much better equipped to engage and to plan things like work commitments, childcare and travel costs if they got plenty of notice and knew what was happening with their appointments and their care and treatment plan. We also know that poverty can reinforce some of the really unhelpful power dynamics that people experience between themselves and clinicians, and that people who are experiencing poverty might feel less empowered to ask for clarification, to tell people that they don't understand and to feel a burden on the service. So this one person, there is a real potential of a missed opportunity here. So they've maybe waited a long time for their appointment and then they've gone and their feedback was he said something about neuro something. I didn't know what it was either. So obviously I've had to Google it. So a real wasted opportunity there for someone to benefit from that clinical interaction. And then in terms of flexibility, one of our clinicians said they do appointments in schools for parents who kind of can't get out to work or can't get up to the centre. So it's thinking about if we're seeing more than one member of the same family, can we coordinate those appointments to reduce the burden? Are they engaging with other professionals in different parts of the system? And can we go to where they are? And even down to things like making sure that we're not having appointments over lunch times. If that person's one hot meal a day is their free school meal, and we're potentially asking them to make a choice between that hot meal and attending a mental health appointment. So what are we doing about it? We're really trying to make the conversation routine. The Money and Pension Service are about to launch their Money and Mental Health Toolkit, and we want to be a really early adopter of that to make sure our clinicians have at their fingertips the information and access to the experts to really embed and weave this into our care without feeling the need to be the experts themselves. Really promoting access to things like our travel and reimbursement policy and making sure that we apply those policies consistent. Being really tenacious and curious when people don't attend appointments or they're not brought to appointments to make sure that that isn't around finance. And if it is, what we can do to help. And then really working in partnerships at place to explore the use of our free assets in our local communities for things like behavioural activation. We've got fantastic library cultural resources and brilliant green and blue spaces up where we are as well. And then we're thinking about how we adopt the learning and adapt it across all our specialties. So the full report is available. We're really happy to share it in full. And if anyone is interested in poverty proof in your own healthcare setting, all of the information about how to connect with Children's North East is on the last slide.
Thank you so much. We're open to questions. Please, if you question, can you speak very clearly, because I think people online are finding it a little bit difficult to hear the questions. So open to questions. Yeah, Isabel. Oh, we have a mic now. Great, that would be very helpful. Thanks.
Thanks so much for really brilliant talk and inspiring work. My name's Isabel Braithwaite. I'm a registrar down in London. It strikes me that this is quite crucial work to be spread across the NHS more broadly, and not just in mental health settings, but across specialties. I imagine that this is the kind of barrier that patients are facing right across the board, and often perhaps quite invisibly. But then we know the NHS is obviously very kind of stretched, and I imagine that financial constraints within the NHS becoming kind of increasingly acute may make it very kind of challenging for this sort of work to happen in a lot of contexts, but perhaps also cultural barriers or perceptions of what's appropriate. I wonder how you think this could be adopted in other contexts, and how different kinds of trusts might try and make that happen. The example perhaps of sort of travel reimbursement strikes me as, even just starting with that, how you would go about making that happen in a regular NHS trust where that's not in place, for example.
Yeah, thank you. So I think there's a couple of things. I think Children's North East, I think we were one of 7 pathways that they were poverty proof in, one of the earlier ones to finish. So we're really keen to see the results from those different sectors across the different pathways as well, and to learn from those, because obviously we were in a community children's service, so nothing came up about prescription costs. We expect that's going to be an issue in other parts of the sector, nothing in terms of inpatient. So again, we expect that might be something. But I think there's a couple of things that we could do to I think really adopt these types of approaches. And one is leaning into the expertise that organisations like Children's North East have, and the independence that they bring, and the external rigour and challenge that they bring to NHS organisations. And I think the other is that we know that things like do not attends are hugely expensive and massively socially profiled. So every time we do a piece of work on do not attends or was not brought, you can see the social gradient really clearly there. And a number of our acute trusts are using that to make the financial case internally, because we can cost out the cost of those missed appointments, and very simple measures can be put in place to try and avoid some of those. And I think also some of the interventions that we're suggesting don't have to cost a lot of money. So making sure that our clinicians have got those tools at their fingertips to have a really broad and rounded conversation, and that they're not worrying about, this might be an issue, but I don't want to open a can of worms. It doesn't cost a huge amount to be able to put that information at people's fingertips. So I think there's lots that we can do that's cost neutral, but we can also feed into something that we know is costing the health sector a huge amount of money.
Thank you. We better move on, Catherine. There are some other questions, but time moves on. So thank you ever so much. Now moving from the northeast to Wales, my new home. Louise Petchy, I hope she's online. Senior Policy Specialist at Public Health Wales, championing health for all in all her policies, and she's led the Public Health Wales Cost of Living Report. And we look forward to hearing about how Public Health Wales and the Welsh Government has been responding. Hopefully Louise is online. No. Yeah,
hopefully you can. There we go. I think you should be able to hear and see me now.
We can hear. Just speak. Yeah, we can hear you. Great, thank you.
I'll just get my slides up. Sorry, your Zoom threw me off, but I'm back now. Hopefully we can get this going quickly. Okay, stop me if you can't hear or see, but I'll assume that you can. So Bodadar, good morning from Wales. I'm Dr. Louisa Petchy, a Senior Policy Specialist at Public Health Wales. And it's a pleasure to be able to share the Welsh perspective with you this morning. In my presentation, I'm going to be focusing on the particular challenge the cost of living crisis poses for health and wellbeing in Wales, and how we at Public Health Wales have taken action ourselves as an organisation and in support of the wider system and Welsh Government to help enable a public health response to the cost of living crisis. I don't know if this is working for you or not.
No, not yet.
Let me just reset and see if that works. Sorry, it just seems to have frozen. Can you see the second slide now? Are you able to see this second slide?
Not yet.
Apologies, there's always somebody that's got to have the tech issues, and today it's me. Right, let me try one last time.
Yeah.
Is that working? Okay, excellent. Sorry about that. Okay, so I wanted to start just by giving a picture of the situation that we face in Wales. So a health impact assessment on the cost of living crisis that was done in Scotland identified these 6 population groups as particularly high risk of negative health and wellbeing impacts from cost of living crisis. So if we look at each of these in turn in Wales, Wales ranks the top of the UK in almost all of them. Highest levels of poverty, including child poverty, more people living with disabilities, more older people, and the second most rural place in the UK as well. I think there's 2 main points to make here. First, that together this makes the population of Wales at particularly high risk of the negative health and wellbeing implications of the cost of living crisis, more so than any other nation of the UK. But second, an important reminder that these are not new problems that we're facing with the cost of living crisis. Almost 1 in 4 people have been living in poverty in Wales for the last decade. And the negative impacts of the cost of living crisis are really so significant because it is pushing on these existing vulnerabilities of poverty and inequality that we have had in Wales for so long. Wow, my internet really doesn't like yours today. I'm so sorry.
In the interest of time, is it possible for you to just maybe summarise the key?
Is this working?
Yeah.
Okay, let's see if please shout if it stops working again. I'm really sorry. So what the cost of living crisis is doing is in Wales is both deepening and widening these problems that we already had. So this is a graphic of financial well-being showing that in October of 2021, 30% of people in Wales were either struggling or in serious financial difficulties. And just a year later, you can see that that number, both in serious difficulties and struggling, have increased, making up a total of more than 40% of the population. And we've probably all noticed the impact of rising costs. But the situation for those who were already in difficulty is now even more dire. And at the same time, we've got more people being pushed from just about coping to a state of struggling or crisis. So in Public Health Wales, we were really thinking in earnest about the potential implications of cost of living in the summer of 2021. And it was only a few months later that we received a request from the Minister for Health and Social Services in Wales for an analysis of the crisis from a public health perspective to help inform how the Welsh Government were going to respond. We used that report to make the case that the cost of living crisis was a public health emergency, as we're discussing today, and therefore required a public health response, recognising the need to respond to the immediate challenge, but also take action now on areas that would bring benefits in the medium term and longer term. To identify those areas for action, we developed a framework to examine how not being able to afford the essentials like food, energy, fuel and housing costs, as well as the pressure of financial stress and debt, linked through to the impact on individuals in terms of their mental and physical health, as well as negatively affecting the wider system. As we were developing that report, we used the learning to reflect ourselves on what Public Health Wales was doing as an organisation and an employer and how we could act to support the response. We established weekly meetings and used them to develop and oversee an action plan covering key areas such as how we were going to support our staff, working with others to create coordinated communications about keeping well in winter, adapting our screening services and other work programmes so that they addressed or focused on the impacts of the crisis, and initiated specific pieces of work to support communities. For example, we developed a resource pack to highlight areas within the Neath Talbot region that were in need of targeted support, such as areas with an older population, poorer quality housing, or higher numbers of people on universal credit claimants. As a result of that reorientation of our work plans, we've developed a range of resources now to help inform and enable the wider public health system's response. This has included collating and sharing international learning on the cost of living crisis and other economic challenges, using our Time to Talk public health survey panel to generate regular insight into how the Welsh population is thinking and feeling about the crisis to help inform the response in Wales in an ongoing and adaptive way. We've also produced guidance on how to apply behavioural science to achieve the impact we want from the way we are responding, and a webinar which brought many of our resources together alongside the expertise of other organisations to help support a coordinated action by stakeholders. We took that kind of convening a step further by holding a cost of living summit this March. The summit was led by Building a Healthier Wales, which is a multi-sector collaboration of stakeholders that Public Health Wales provides the secretariat for. The summit drew in over 180 people from a diverse range of organisations, public sector, Welsh Government, local government, voluntary organisations and think tanks, to help develop a shared understanding of key action areas at a national and local level. And you can see a summary of what came out of those discussions, where we identified short, medium and long-term actions, both at a local and national level in that yellow table there, with a more detailed report due to be published very soon. Polling on the day found agreement that the cost of living crisis is a critical health issue in Wales, but across the board, like I think has already been mentioned in the previous speaker, there's a real lack of confidence in their ability to be able to make a difference, and that sort of sense of hopelessness and overwhelm. But crucially, I think people found the summit really useful, with much of the feedback focusing on how that collaborative working across the system that the summit had helped to kickstart was really welcome, and reinforcing the point that bringing people together to work through this issue is absolutely key. In our initial report, as you just saw from the summit, a shared message was the need for the response to the crisis in Wales to do three things: to recognise and respond to that immediate threat that the cost of living crisis poses to health and well-being, with a greater focus on supporting those who will be hit hardest. 2, to take action now on some of these policy areas to benefit people's health in the more medium term. And 3, to at the same time also prioritise action that will build a healthier and more equal society in the longer term. With that in mind, I wanted to finish my presentation by talking a bit about what that looks like at the national level, by highlighting some of the key elements of Welsh Government's response to date in those short to medium term action areas. They include the fuel voucher scheme for eligible households, for example, those on prepayment meters, and the Wales Fuel Support Scheme, the latter costing 90 million in 2022 to 2023 and not being continued into this financial year. There is also the Cost of Living Support Scheme, which gave a one-off payment of £150 to eligible households, and the Discretionary Assistance Fund, designed to support those in extreme financial hardship, which gave out 23 million last year and has been allocated an extra 18.8 million in this year's Welsh Government budget. Welsh Government has also provided recurrent funding of around 70 million to local authorities and health boards to implement the real living wage for social care workers, and in alignment with the cooperation agreement that exists between the Labour Welsh Government and Plaid Cymru Incentive, has committed to expanding free childcare to all 2-year-olds and free school meals to all primary school children. On broader themes, Welsh Government has also prioritised funding for the basic income pilot for care leavers that's currently ongoing in Wales, for pupil deprivation grants and homelessness support. They've committed to investing in public transport and continuing their Warm Homes programme that looks to improve energy efficiency. Welsh Government have also provided extra support to voluntary organisations and a degree of business rate relief for retail, tourism and hospitality businesses. Now, I know that's a bit of a whistle-stop tour of some of those interventions, but there is more detail in the links when this is shared. Now, bubbling away in the background of all of this, there is also progress being made on those longer-term elements. And this is aided significantly by the enabling policy environment we are lucky to have in Wales. This includes the Wellbeing of Future Generations Act passed in 2015, which puts a legal duty on all public bodies, including Welsh Government, to maximise their contributions to 7 wellbeing goals, including a healthier and more equal Wales. Public bodies also have a legal duty when making strategic decisions to have due regard to the need to reduce the inequalities of outcome resulting from socioeconomic disadvantage. And we soon expect regulations to be laid in the Senedd that will require public bodies to carry out health impact assessments. Supporting the system to put these enabling policies to best effect, even in what feels like a very pressing crisis, and keeping this long-term prevention perspective ensures that we take action on the underlying issues such as poverty. And that's where we see that this public health lens in Wales can be adding real value and hopefully help to build from this crisis a healthier and more equal future for Wales. That's all from me. Diolch yn fawr. Thank you very much. Apologies for the tech issues, but I look forward to answering any questions you might have time for.
Thank you very much, Louisa. It's clearly a good country to move to, with lots of great actions going. I think we're going to have run out of time for questions because we must give Ms. Breen a chance to speak. So if you do have any questions, perhaps they could contact you directly or feed them into the Q&A, and we'll try and pick them up at the panel session. So thank you very much. And so it's my great pleasure to invite Nisreen Alwan to give our last talk this session, a former colleague and collaborator at the University of Southampton, where she's Professor of Public Health, expertise in life course, EPI, maternal and child health, health inequalities, and of course, long COVID. And look forward to hearing about food insecurity. And
right, looking at the time, thank you. Thank you very much, Paul and everybody. So yes, just a few thoughts on food insecurity, some local and national work we're doing. This is the team. I'm here really as mainly as an imposter because the stuff that I'm presenting has been led by other members of the team. So bear with me. Does this work? Okay, so statement of interest. We're asked to put this. This work is funded by NHR Applied Research Collaboration Wessex. Actually, I would like to take the opportunity to say Applied Research Collaborations, known as ARCs, are actually great opportunity for those of us working in academia to do local and regional work. We're always very keen to do that, but all the tensions around kind of funding and impact of research, etc., sometimes stand in the way. So shout out to ARC, to ARCs, the NHR ARCs across the country. We did this project, which is called the Wessex Friend Family Risk Identification Decision. There are bits in it that are focused on the prediction of child obesity. You can see some papers there around kind of developing models of early prediction of child obesity, and then validating them, and then providing a tool for disadvantaged families to work with the health visitors around the prediction of childhood obesity early on, pregnancy and early life. I'm not going to talk about this. I'm going to talk about the bit in the middle, which says where we tried to combine individual risk measures. So these are the individual kind of predictors with area level predictors to kind of focus interventions. So green space, food insecurity, and child poverty. Dr. Diana Smith led this work. Basically, she led these consultations with service providers, local government representative, looking at maps of estimates of food insecurity, discussing, where the need is. And we thought we were doing it in Wessex, but actually Diana thought we could actually do this nationally. So developed this food insecurity index, which basically started by updating more generic measures of relative deprivation, existing measures of relative deprivation, including some work she's done in the past. And then we added distance to medium and large supermarkets, so a bit about the structural kind of aspects, and some additional data to represent newly identified risk factors, which I'll tell you about in a minute. And made the methods available and free to all. So this is what the kind of the domains of the food insecurity index. There's the compositional domain and the structural domain. So composition is about kind of who lives in these areas, claiming of benefits, people on low income, educational qualifications, and mental health. But also there is the structural kind of dimension, which is kind of minutes to, recent employment center by public transport, distance to supermarket, as you can see. So that combines the index. You can see the map here. unsurprisingly, as we've heard this morning from Sir Michael, the highest tend to be in the north. About a third of the high-risk areas are the northwest. 96% are urban versus rural areas. We validated this looking at, kind of against things like free school meals, child obesity, prevalence, index of multiple deprivation. And explore the urban and rural areas separately, because there are specific challenges with rural areas, particularly around the structural dimension. And there's a paper there. This has been good because it's been help targeting resources in neighborhoods, joint strategic needs assessment, food poverty action plans, data and maps been shared widely, and you can see the website there for anybody who would like to use it. It's called My Local Map, which you can kind of use and other people are using. This is a quote saying that how it's been used to confirm really what local practitioners know about certain area in terms of needs. The index covers is lower super output area level, so about over 30,000 kind of areas, which each one of them covering 1,000 to 3,000 people. So it's quite a good for local use. This is another piece of work we're doing as part of, or we did as part of Wessex Friend, led by Dr. Grace Grope, and we talked to health visitors and parents, particularly around, disadvantaged areas. These are the parents. We were focusing on the kind of prevention of child obesity, but we looked at food insecurity, and particularly around the Healthy Start voucher scheme, which is basically, vouchers that, allow pregnant women and families, young children to have some extra money for kind of healthy foods and milk. Some quotes from the parents around food insecurity. My grandma helped me a lot. She actually takes me food shopping once a month because I'm on universal credit and I'm a single mom, not by choice, but I barely afford my bills, let alone food on top of that. I get Healthy Start vouchers that increased, as you can see from the quote. Before I could just buy milk and maybe a bag of apples, and now I can afford to buy some grapes or something. And then you can see this one about, this week I got chocolate cakes, donuts, some bread, some beans, and some pasta. And you can see the types of food that people can get when they're food insecure. The one quote I'll read from the health visitors is not having a car. They're relying on bringing that back on the bus. So they tend to get things more locally, and that's more expensive and less healthy. That's a really, really important theme. Local shopping, local food is more expensive and less healthy. And that's a clear action plan for us. We need to reverse that because that's not good. So some themes here. So there has been impact of COVID. Obviously, families with young children prioritize the child in terms of their food insecurity, and the health professionals, in order to not break kind of the trust, sometimes are reluctant to kind of discuss sensitive issues such as, prevention of child obesity, healthy diet, food insecurity, and that's something that we need to make sure we account for. So some barriers to healthy eating: cost, obviously, availability of equipment, oven, fridge, time traveling to supermarket, time preparing food, food preferences, particularly for children, that people don't want to buy food that will go to waste for the child to try new types of food in this, in food insecure household. And obviously transport, discounted or free food, obviously food bank, food pantries, family support is really important. Healthy Start actually helps, and we are looking at new ways of looking at it. Very quickly, we are now looking at we're doing another project determining the impact of food insecurity in young families, and this is basically looking at things called food pantries, which is kind of the level up from food bank, where there's a weekly membership that families can pay, giving you a couple of examples from the ones we have in our study: Southampton City Mission and Southampton Social Aid. But basically, it's usually they pay about £5 and they get about 5 items in some of these schemes. And some of these schemes will have fresh fruit and vegetable or something frozen, so which food banks don't have. But also there's a social element to these schemes because people can kind of come every week, see other people they know and have a chat and have a cup of tea or coffee. So there's that dimension as well. We're doing that research. We've so far recruited 97 and you can see in terms of food insecurity, and majority of them based on validated measure of food insecurity are food insecure, and the vegetable and fruit charts here just tell you that in terms of their quality of diet, they have relatively low intake of vegetable and fruit. Some quotes here from a married woman, 3 children, full-time mom. I've noticed that I'm kind of having more fruit and vegetables since I've started going to the food pantry. I love it. I absolutely love it. I've gone to every single week since it started. I love the community, speaking to the volunteer, and just have met quite a few new people, which is quite nice as well. And it's just as nice to be kind of able to save a bit of money because before food market, me and my husband were constantly in our overdrafts by quite a lot. This is my last slide, I think, Paul. So this is just a couple of other quotes. I'll read one of them. And I found as well, I could get sort of like a week's worth of shopping, although you can only use up to a £5 and you can go around and get yourself. But after a couple of weeks, that built up to the bits and didn't use. So that's building up, going every week. So it was like, having really full cupboards again, and it was great. Thank you very much.
Thank you so much, Nisreen. I think you've got your link there. We are a little bit short of time because we've gone through 5 fantastic talks and pretty rapid firing in and out. So if you want to get in contact with Nisreen or the team, I think the links were up there. So I'm sorry we've not much time for questions here. And again, questions come on the chat, we'll try and put to the panel. So thank you, Nisreen. I think it's time to hand over to, so I should thank all 5 speakers while we're I think you've heard the diversity of approaches across the country, and there's a lot of action and great public health work. So thank you, all of you. So I hand over to Phil. Thank you.
Hi everyone, I'm Phil Satherley, Policy and Public Affairs Manager at the Royal Society of Public Health. I'd like to introduce Rachel Bone, who is the Head of Policy and Research at Trussell Trust, and is going to be talking about all of their work. So over to you.
Hello. I think my slides are going to appear if I'm magic. I'm really sorry. I am the thing standing between you and lunch, but brace, we can do this. I Head of Policy Research at Trussell Trust. I'll tell you a little bit about what Trussell does. But before I do this, when I do presentations like this, I often feel a little bit like I can be the harbinger of doom. I have to come up here and tell you all what it's like at our food banks. And spoilers, it's not great. That's why I was just so grateful for our chairs at the start, really kind of laying down an invitation for us to talk about solutions and not just problems. And it's been really inspiring over the last hour to hear about some of those on the local level. I'll be zooming back up at the end of my talk to the national level. So Michael says that that's where it needs to change, and I totally agree with him. So here is what she says we're going to cover. Right, so I'll do a little bit about Trussell Trust. I will then tell you about what we're seeing at the moment at our food banks, and then I will give you the answer, what needs to change and solve all our problems, and maybe we can all go home after lunch. So the Trussell Trust. We are very proudly a food bank charity that wants to do ourselves out of business. We support a network of about 1,300 food bank centres across the UK, set up about 25 years ago by a couple in Salisbury who were really horrified by the levels of deprivation that they were seeing on their doorsteps. They started in a garden shed, more or less, and over the last few years, it's grown, and now, 1,300 centres across the UK. People go to them because they are referred by external agencies. That might be a GP, it might be a teacher, it might be the Citizens Advice. They've been identified as not being able to afford the fundamental essentials that we all need to survive. So they turn up at the food bank and they're provided usually with 3 days worth of emergency food for them and their households. Sometimes it's a little bit more. They also get some wider support. So all the volunteers and staff at the food bank will sit down with them and understand what is going on in their lives to kind of lead them to being in this position. And often that will involve advice on how to kind of maximise their income. Now, staff and volunteers at our food banks are really, really passionate about what they do, but even more passionate are they about the fact that they shouldn't need to exist. Now, I imagine I'm probably preaching a little bit to the converted here, so I won't spend too long. You don't need to get your violins out, but it is insane. And I think it's often easy to forget when food banks are talked about so much in the media these days that our country is being propped up by food banks, that people are getting to that stage having turned down their heating, turned off their heating, sacrificed their own meal for their children's meal, stopped using transport, many, many weeks ago, and are now at the point where they can't afford food. So while we will continue to support our network of food banks to provide what they need for their communities for as long as they are needed, we're also working towards a country that doesn't need them at all. So we're thinking big on policy, we're thinking big on the minds and hearts that we need to change as well as policy. So yeah, that's my kind of pitch, and I'll start to talk a little bit about what we're seeing. One final thing before I move on though, the Trussell Trust has become quite ubiquitous with food banks. We're just one part of a much, much wider infrastructure. So when I talk a little bit about the numbers that you're going to see over the next few slides, please remember that like we're just one part of the puzzle and we're not even the majority part of that. So this is a bit of the tip of the iceberg. So I spoke about our vision for a world without the need for food banks. It always felt fairly ambitious, I'm not going to lie, and I guess more recently it's felt even more so. And that's a little bit because what I'll show you now. Having this network of food banks allows us to see the levels of need over time. Everybody uses the same data system, we can track need over time. And our most recent statistics, this data point down the right, represent last financial year. So April 2022 to March 2023, I guess kind of seeing a real kind of peak of the cost of living crisis. So what this shows is nearly 3 million emergency food parcels given out in the UK. That is the highest number we have ever given out. 37% increase on previous years. And it's worth saying over this entire period, the number of food banks has stayed fairly consistent. The real growth we saw was before that. So it's not because there's more food banks, it's because the need is growing. You'll see for the first time on that green line, fairly miserable milestone of surpassing 1 million food parcels for children. So it's really great to hear about the kind of focus on food poverty for children being talked about so far. And you'll see that other kind of peak back then from the pandemic. We thought that would be the busiest year ever. This year it was 16% higher. So that's this year, and I know we're talking about the cost of living crisis and kind of how that's been kind of come to understand over the last year or so. But one point, if I can just leave one thing with you, and I know this has been talked about a little bit so far, this is not a new phenomenon. It didn't start with the invasion of the Ukraine, it didn't even start with a pandemic. What we see here is a 5-year trajectory, and this is just kind of where the stats that we started collecting kind of starts, but an upwards trajectory of a cost of living crisis that for many people has been going for 5 years, not 1 year. So we talk about these two events, the cost of living crisis and the pandemic, not being the main cause of food bank use, but being something that has both exposed it and exacerbated it. And I think it's really, really important that we don't get too focused on what's happening in this year and think about kind of this overall trend. We're fairly clear, and we'll talk a little bit about this in the final section, that there is a fairly clear driver of this, and that is an insufficient and inadequate social security system. That's what's causing this. So that's not to say there haven't been changes from previous years, and we'll just talk a little bit about those. So first-time users are rising. We saw 360,000 people, and we've kind of drawn that from the 328,000 families that have been used food banks for the first time. That figure of first-time users is 38% higher than last year's first-time users. We also talk about deepening hardship. I feel a bit funny describing deepening hardship. Hardship was pretty deep beforehand, but what we kind of mean by that is food banks who have been doing this work for years and years are being shocked in a way they never thought they were going to be shocked. There's a quote there that speaks to really what that has looked like over the winter. But we see just how that kind of translates to what the food bank's having to do as well, operational changes. So we found last year that 1 in 5 people referred to food banks were from working households where, you know, someone in there is earning. That's something that we haven't heard from our food banks in quite that number before. And that's why our food banks are, for the first time, having to change their operating hours so that people can go before or after work. So I talk about deepening hardship. It's always been deep, but it's a different kind of complexity that we're seeing at our food banks. So I said I would be the harbinger of doom. It isn't pretty, and you will all know that from your work in the public health space. But that doesn't mean that you need to leave for lunch really depressed and miserable. I've got some good news, because we do believe that change is possible. I'm going to massively simplify it down here. Obviously, change is needed across a huge range of levels of government, of different areas of policy. But we are very clear that there is one thing that would make the biggest impact on this. Social security, our research has found, is the main driver of food bank use. It is not enough for people to afford the essentials, and the vast majority of people that come to our food banks are in receipt of social security. Now, you probably know this as well, but that doesn't mean there are people on benefits and there are people in work. A lot of those people are also working, but their earnings are not sufficient, so they are subsidised by social security, but they are still not enough to afford the essential. And it's not hard to see why. So Michael, you showed the income replacement rates for sickness. This is it for benefits. So what this shows us is that universal credit standard allowance, which is the kind of the fundamental building block of benefits, how that has reduced over time as a proportion of the average earnings for people. So what that means is if you are on an average salary and you lose your job tomorrow, actually not tomorrow, it takes you 5 weeks to receive your first payment of your universal credit, but in 5 weeks, you will receive about 14% of what you were on beforehand. Now, when we think about how much an average person has been struggling over the last year to survive the cost of living crisis, and then we think about what it must be like to survive on 14% of that, it's not hard to imagine why food bank use is where it is. And there's also a very good reason, well, there is a reason, I wouldn't say it's a very good one, for why this is the case. And that is because universal credit isn't based on anything. Now, that might feel like a bit of a mad thing to say, and actually we've heard from DWP ministers or ex-DWP ministers who were very surprised when they found it out themselves and they walked into that department. But there is no rational or consistent or objective calculation for how much people get in their benefits. So there's no assessment of what people need to survive and how much that costs. It's just kind of a historic result of sometimes inflationary rises, sometimes other things, but there's not kind of a systematic way of doing that. Thank you, Sir Michael, for showing some of this in your previous slides, but we did a calculation to work out what we thought, incredibly conservatively, we thought people needed to afford the essentials. That's this table on the right. We really do think it's quite conservative, and actually we've polled it publicly and people think it's quite mean, really, but £120 just to get by, to afford food, heating, communications, travel. When you look at the graph on the left, and this is the one that Michael showed earlier, you see the gap. So for a single person aged more than 25, they are £35 down on what they need to afford the essentials. It's a bigger gap if you're under 25. And for a couple, you see that on the right. So it's pretty blooming obvious why people are turning up at food banks. It is physically impossible to afford what you need to survive on the amount that you're getting in your universal credit. So we think there's a solution for this, and I'll leave this with you, but I'm also really keen over lunch and others to kind of hear a bit about what you think about it. We're calling for the UK government to guarantee our essentials, to provide a guarantee to all of us as a nation that universal credit will always be enough to provide that basic safety net if some of us can't be able to work. So what that would look like is an independent process to do that objective calculation on a regular basis to say, what do people need to survive? How much does that cost? to advise the government, and then that the government would commit to making universal credit at least that, and that nothing kind of could take them below that level. It's a big change, but we think it's one that would make a lot of sense. We think it would make a humongous difference to the millions of people in poverty. And fundamentally, we think while it would be a good economic decision, a good moral decision, we hope, and I hope you agree, it would be a good public health decision as well. But I'd really like to hear your thoughts about how we kind of better articulate that, because that is not my area of expertise. So Michael, you invited us to make hope possible. I hope I've given you a bit of a flavour of that before lunch, but thank you very much for your time.
Maggie has had to leave to go take a call, so I think in the absence of anybody else, I believe we go for lunch now. Good. I've got one thing right today. The lunch.
Slightly bad.
Oh, yeah.
I was in here rehearsing.
Is it? Is that it?
Start the recording. Could I have your attention for a moment, please? Thank you, everyone. Could I just have your attention for a moment before we start recording? We wanted to make sure that our in-person audience were aware that after the conference closes tonight as planned, we
Super. And are we now live? Excellent. Thank you. Well, great to be with you all this afternoon. I hope everyone enjoyed lunch. I'm Johnny Pearson-Stuttard and chair of the Royal Society for Public Health, and delighted to be with you this afternoon, and particularly for this session we have now, which looks to be a really interesting and engaging session. We have 5 speakers, each of which are going to talk for around sort of 8 or 9 moments. And then we'll have a couple of minutes for questions after each speaker. So do think of the questions as we go. I'll invite questions for each of the speakers afterwards, and then we'll move on to each of them. Following this will be the voting of the statement, then break. So plenty of time as well to continue the discussion over the coffee break then. So to start us off, I'm going to ask Susan Meakin is going to join us here, who's a solicitor and council member of the Epidemiology and Public Health section here at the Royal Society of Medicine. And over to you, Susan.
Fantastic. Absolutely. Poverty and the cost of living crisis, public health emergency, where public health meets public law. I'm Scots qualified and English and Welsh qualified, so I think we've got the UK covered. And actually, ironically, the focus is going to be on housing and fuel poverty and how they interact together. Public law is quite different in Scotland, north of the border, compared to England and Wales. In some ways more advanced, in other ways more under attack. Public health, the science and art of preventing ill health. Public law, law of relations between the individual and the government or the state, and secondarily, and rather importantly, I think for this context, the body of law governing conduct of public bodies, health trusts, charities, housing associations, social housing, local councils, you name it, NGOs, they're public bodies. Oops. Classic headlines, we've all seen them. UK housing stock, the oldest in Europe, one of the oldest in the world. Damp, mold and leaks abounding. Rent caps only, we're talking about social housing, private housing, nothing to do with commerce at the moment. Rent caps are in Scotland currently the subject of judicial review and legal challenge. Private landlords have come together to say that what the Scottish Government introduced last September in relation to rent caps, which they've now lifted for social housing and public housing, is discriminatory, because they're saying that why should private landlords not be able to get the income to renovate their properties, as the law requires them to do increasingly. And they're saying that it's irrational, the policy that the Scottish Government is pursuing. Rent rises all over the UK. REIT Investment, that's a real estate investment trust currently gone bankrupt in London, a mix of charities as tenants, lead tenants, all the way down to individuals and families in their properties. They couldn't get certification for housing benefit, and I'm going to be talking about that in the next few slides. Obviously, very well known, recent coroner's inquest conclusions, the ADPH case at Rochdale Borough Council, and finishing up with some comments from the CMO and the Environment Agency, where they were actually talking about sewage and the investment and commitment required to tackle that, but I'm going to be borrowing their remarks because they're very pertinent to housing and fuel. Fuel poverty, of course, interacts most perniciously with cold, damp housing. Your mental health, you're spending your money trying to comply with your own tenancy agreement, heating your home to a minimum statutory level, and of course, the bills are absolutely rocketing, and the lack of insulation makes it almost a physical impossibility. But it isn't just insulation, of course, that connects with leaks, mold and damp. Ventilation is actually the crux, and it's ventilation in tenancy agreements, which we'll see in the next slide, which actually contains the mutual obligations of the tenant and the landlord in relation to the property. If the property is poorly designed, the only window that you've got opens out onto an enclosed corridor, as was the case in the ADPH coroner's conclusion, then it's pretty much physically impossible to properly ventilate your kitchen and your bathroom in particular, where damp is always arising. And doesn't matter how much fuel costs you're expending in that property, it's so poorly designed, you're not going to manage it. Long-term solutions, investment, innovation, commitment, preventative engineering and management. Nothing cheap, quick or easy here. Some stats. Mouldy homes, a national disgrace. Freedom of information, nearly 6,000 complaints. This is January to March 2023 to the Housing Ombudsman. Nearly 4,000. This is all about mould and damp. About housing association properties, nearly 2,000 were sites provided on behalf of local councils. And remember, they're all under the statutory duties to maintain their properties. It's estimated nearly 3 million homes in the UK have damp, mould and leaks, and that's a conservative estimate. And no one is spared naturally. Housing association, private, rental, military accommodation, the Ministry of Defence can't put army families into their accommodation, which they own and manage because of their own leak and mould problems. Social housing and of course privately owned and rented out properties are don't escape the scourge. Coming to a really important legal point, the legal position. No one should be coy when they're talking about mutual covenants in any tenancy agreement. And that is the undertakings on the tenant to properly ventilate and maintain the property with minimum heating. If that is being done and damp and mold are still present, then that issue is structural, and the entire responsibility of resolving that shifts on to the landlord. Every kind of landlord, private, Ministry of Defence, social housing, local authority. That issue is structural. They're the ones that have to resolve it. I think I've recently noticed as a lawyer that there seems to be a slightly coy thing about, oh, we mustn't imply that tenants have some agency in their own tenancy agreements. Well, if their tenancy agreement doesn't contain these mutual covenants, that's in the contract, then it ain't a tenancy agreement. And it's the mutual obligations contained in those tenancy agreements that gives the tenant the legal right in public law to enforce their statutory rights. Because it's one thing to have a right under the Shorthold Assured Tenancy Act 1988. It's a completely different thing to be able to enforce it. So in February this year, the interim chief of Rochdale Borough Housing was on Radio 4. She said nearly 15% of their homes have problems with damp, and she said probably more. That this is one housing association. That was nearly 2,000 properties out of 12,500 properties. You'll recall that that's the housing where the family of Ewa Bishat lived. The 6th housing secretary in 12 months, it's currently Michael Gove, but you know, don't hold your breath, could be somebody else by the time we come out of this conference. The 6th housing secretary in 12 months immediately stripped £1 million from Rochdale Borough Council government funding. The chief exec and the chair were forced out. I think that's the correct term. And so it was the interim head. And this gave an indication as to what this government's response was going to be. So proper funding is really required by local authorities so they can meet all their statutory duties. Currently, edicts are being issued by Michael Gove as the housing government minister, but without the extra funding required to make the stricter time limits that he's now imposing by statute for fixing mold and damp, but no extra money to do it. Wholly logically, local authorities then seek to raise council rents, and their council tenants and local authority tenants legitimately expect a higher quality service. Those rents have been increased by twice as much as normally would be the case. Inflation's at a 40-year high. Interest rates are affecting the loans taken out by local authorities and councils, which they use to finance estate regeneration schemes. And so it's a spectacularly non-virtuous circle. So what's required? Housing and building retrofitting, enforcement of their rights to address the mold and damp. And these are the words of the chief medical officer with Ofwat and the Environment Agency. They were talking about sewage in English waterways, but it actually occurred to me that the three leading remarks were pretty apposite for this problem. A serious public health risk, increasing rather than decreasing. It requires investment, preventative engineering, better building management, innovation and commitment. And you're only going to get that commitment by having the sanction against any landlord of being able to enforce your legal rights. However, the bad ferry round the cradle, retrofitting, be careful what you wish for. Do we have an example where some country has attempted to use cladding? Here, post-Grenfell, we think of cladding as a flammable issue, you know, a fire risk. In New Zealand, 20 years ago, they applied very expensive cladding to very expensive apartments in Auckland and New Zealand. They ended up trapping mold and dust that subsequently fed the mold in all the crevices and cuffs of the building. Almost overnight, they became uninhabitable, uninsurable. People had to carry on paying their mortgage. They couldn't put tenants into them because they were breathing toxic mold. It ricocheted down through the New Zealand housing economy. It's a problem they're still struggling with today, and it was known for short as leaky building syndrome. So if anyone jumps up and suggests that we've got some quick and easy engineering solutions here, no, I don't think so. And any suggestion, for example, talking about litigating at coroner's courts and that kind of thing, no one litigated at the coroner's court. The bereaved are at the heart of the process there. It's inquisitorial, not adversarial, and you can't use a coroner's court to air grievances. So if anyone is implying that solutions exist for this housing problem, mold, leaks and damp, that can be quickly implemented, and it shouldn't be any public health person, I would venture to suggest, then I'm afraid they're absolutely wrong, and they're allowing optimism to cloud reality. There we are.
Thank you very much, Susan. Lots of food for thought. I've got a couple of questions. You've left lots of thoughts that give me lots of questions, so I'll look to ask you at the break. Any questions in the room? And those online, please do type your questions in as well, and we can ask Susan directly. Any questions in the room for Susan? And whilst people are thinking, Susan, my question was, is there any cause for optimism? You said that the mold and damp impact, in the sense of, are there any examples that you know of within the UK where actually local authorities have been able to tackle this in a way with a clear outcome that's improved, or is this just something that we're at an impasse and without central government's movement here?
Well, absolutely crucially, it's going to be collaboration between public and private investment and public and private engineering groups and strategies. Yes, for example, there are already housing estates in London called Passivhaus. They've borrowed it from the German Passivhaus, ich spreche Deutsch, and that means a house that's breathing on its own. And I noticed just in the local paper just yesterday that it was thought that mold had developed in one of these leading 2018 housing developments where an 89-year-old lady had a mold problem. But the spokesperson for the Passivhaus builders and developers said, no, it's not the building. It's got state-of-the-art ventilation. It was a leaking device from the flat up above. And they were able to zip in and fix the mold. Developed, mold will grow where any moisture is gathering in the crevices and corners, and they were delighted to report that the ventilation state of the art was very effective. So we have the technology, Captain, but we're just going to have to front up with the funds, and that's got to be a mix and a collaboration between public and private.
Thanks, Susan.
In my view.
Sorry.
Thanks, Susan. I mean, is there naively any pressure on the legislative side of things that we as public health institutions could make? Or is this ridiculous? Could we get the law changed? By whom, how?
Yes.
Because I think without squeezing the rich people and making their obligations legal and enforcing, we're probably not going anywhere. Anything we can do legally?
Well, driving a wedge between the private rental sector and any public social housing is not the way to go. And we already see it in Scotland because the SNP devolved government there 6 months ago introduced their rent caps across the entire sector, and everybody put up with it for a while because obviously the winter was coming and it was understood there was a cost of living crisis. But then at the end of March, they lifted it for all social and housing associations. The rents promptly rose 7 to 9%, and there was big protest from their tenants about that, but not for the private rental market. In short, it seemed to me, I've got a foot in Scotland and a foot down in the south, that they were seeking to drive a wedge and tell the private rental sector, you've got to behave as though you're a social rental provider. You've got all the responsibilities, but none of the legal rights. And the private landlords, needless to say, turned around and said, we'll see you in court. And they've already started judicial review. It's discriminatory and irrational. And they've borrowed that from case law and statute. I'm not going to give a prediction about whether they're going to win, but I've already read the initial pleadings and they're pretty sound.
Thanks, Susan. Lots more to think about there as well.
Yeah.
Thank you. So next, I'll ask Professor Jim McManus, President of Association of Directors of Public Health, please.
Thank you. I don't have PowerPoint because I thought you could do with a time off for good behaviour. and I'm going to focus on action. And I think Susan's presentation is an extremely good reason why you should get lawyers involved in any long-term policy action on policy health. Whether you may not be able to get statute, but you can always use case law and precedent. But I'm going to give what I think are 6 way markers for how we act, or 6 opportunities. And you know, Michael talks about proportionate universalism. Well, I talk about strategic opportunism, which is be strategic and grab opportunities when they come up, but don't accept any counsel that we can't push anything with governments or policymakers. We can only grab the opportunities that they arise, because I think that's a dereliction of our duty. And I think we have to grab opportunities, but we have to be strategic. I'm going to give you 2 examples. In 1905, St. Joseph's Hospice opened in Hackney. I'm a trustee. In the words of the foundress, give to the poor out of love what the rich can buy for money. And 118 years later, we're still there. The biggest hospice in the United Kingdom, one of the oldest in the United Kingdom. And we have driven down bed sores in our most deprived people in London to a level that is way below the national average, having started way above. Just one example of doing things that are strategic, but opportunistic as well. Grab the opportunity and be strategic. The other example is when I was clearing out my mum's house. She was a factory worker. She lived in the council house. I found a paper by Professor Stone in the Journal of the Royal Statistical Society, which of course we all read, from 2000, that talked about how actually the Scottish Catholic education system had systematically over 100 years taken people like me from being the son of a bus driver to being a director of public health. So don't believe that being strategic or opportunistic can't work. And actually often this strategic action is done by non-governmental action agents. My first watchword is channel our passion. There's no point being angry unless you're going to channel it into doing something constructive. Are we here to do good, or are we here to feel good? I'd rather do good and realize what I haven't done than feel good about something. So be aware of our emotions. I mean, you know, who's not in the room because of their values? How many of you do this job because you want to change the world in public health? That's what gets me out of bed every day. The second thing is use our public health skills in a world where ideology and misstated evidence trumps, as we heard from Michael. You know, the stuff around with the biggest tax burden and the data contradicts that. What do we have? We have the ability to analyse need. We have the ability to analyse evidence. We have the ability to formulate interventions. We have the ability to measure their impact. But what we have to do is find ways of communicating that more impactfully. Go back to the sources of our skills and our knowledge as public health people and start from there to channel. That has to be a way we work. I think the third way marker is we need to build coalitions of hope. We need to build those at national and local level, but we need to build them. And hope is not optimism. Hope is actually something that sticks and will find ways round and will find ways and means. And that's where good lawyers come in. I think the fourth way marker is when you're building those coalitions of hope, think about multiple layers of action. What can you do at local level? Brilliant example from Swindon. I tweeted the Local Government Association in ADPH annual report. You know, there's nearly 200 case studies of what local authorities are doing on cost of living on the LGA website and the ADPH website. We have 11 streams of action in Hertfordshire alone. And one of them is we created behavioural sciences guidelines on how we communicate to residents about cost of living to empower, not stigmatise. If we are not doing this out of love and hope, Sandra Galea, the epidemiologist, talks about public health as being an exercise in love at population level, then why are we doing it? And if we are doing it out of love, let us empower people, not stigmatise them. So local and national levels and timescales. There's nothing stopping us thinking 10, 20 years. Electoral cycles might be 4 years. I've been in my job for 10. I've been working on things that are beginning to take fruition now that I started 10 years ago. There is nothing to stop you doing what you can to take long-term action, but you do need legislative change. I would like to propose that at national level, we really need to use policy network theory, because there are things that we can achieve by all of us talking together and using our own words to promote some core messages. You heard from the Trussell Trust. We've got the Health Foundation in the room, great advocates. We've got so many of us. How many coalitions or networks can we use to say there's so many things from different voices that people have to listen to the evidence? It's been done before. It has been done before. We wouldn't have equality for women in pay, allegedly, if that hadn't happened. We wouldn't have equality for LGBT people or the equalities that we have if we hadn't used policy networks. There are tools and mechanisms we can use. I think the next one, the fifth one, and I'm rattling through these, but I promise you I'll write them up, is the challenge of policy which relies on either ideology or misstated evidence. Now, there's nothing wrong with ideology. We've all got them. We've all got values. But there is something wrong when our ideologies are harming people. And there is something wrong when our evidence is misstated. So how do we use our coalitions of hope to actually identify the harm that is being done? And I think Will asked the right question. It's not that there isn't enough evidence, it's that we're not articulating it in the right way, in the right places, to the right people. That's not a criticism, it's just we need to get better at it. And then finally, I don't know how many of you have read Mariana Mazzucato's books. The latest one is The Big Con, on how this idea that the public sector can't innovate. And all the evidence is nonsense around that, of course. But there's a book she wrote called Public Purpose and another one called The Entrepreneurial State, which are way back before she wrote this, The Great Con. The public sector has not only a moral value and a public good, which is why we have public law, but it actually has a value in innovation, a value in delivery, and a value in what it does. Otherwise, people wouldn't be so hang up around measuring it. Think about it. So there's an ideologically driven point about private sector is better. No, it isn't. Actually, both have ways of delivering value. And we need to rediscover, actually, that there are some fundamental philosophical points at the root of addressing poverty. And one of which is that it is a moral affront to the flourishing of our fellow human beings. And the second is that it is harmful to the state, it is harmful to the economy, and it is harmful to human flourishing. And so any self-enlightened government would want to tackle poverty, and we need to be reframing the debate. And so these 6 waymarkers, when I started out in local government in 1990, I think things were just about put in English and not in Latin. We had an anti-poverty strategy. I am dismayed that we are around to having anti-poverty strategies again, but I am determined that for as long as I have breath, I will do my bit, and directors of public health around the country are doing that. So those 6 things have worked for me in my life. I offer them to you in the hope that you might find some use from them. Thank you for listening.
Thank you very much, Jim. Any questions in the room or online? And if you could introduce yourself, if we start over here and then into the middle here.
Thank you so much, Jim. Nisreen Alwan, Professor of Public Health, University of Southampton. So, hi. So, really glad you touched on ideology versus evidence, because there is a thing about that you know, if we're passionate about what we're advocating, we get accused of being ideological. Now, I know that my ideology in public health has been informed by evidence. It's evidence-informed ideology. I have it, but it's evidence-informed. And And I think what you're saying about communicating and really being kind of activists for public health does involve a bit of ideology. But I think in our public health community, we tend to kind of get a bit scared and shy away from being accused of that. So any thoughts on that?
So I think the first thing, and I think you're right, I think the first thing is de-weaponize it by using the word worldview, not ideology. I think the second thing is, because actually if you didn't have a worldview, you'd be dead. And the second is examine your worldview and make sure it is consistent with evidence. I think if you're in public health, we have a duty not to let our worldviews interfere with what the evidence says, but we also have a duty to come from the values that the state tells us are important: justice, equality, flourishing, and health. Those are values that the state asks us. Every state in the United Kingdom has asked us. I think the third thing is, what did we learn during COVID about the promotion of pseudoscience and myth and misinformation? We learned actually that it was, a lot of it was ideologically driven. So do not be on the defensive, be on the assertive about saying to people, well, where's your evidence? Where's your ideology? This nonsense about ivermectin, the nonsense that masks don't work. There's plenty of evidence masks don't work. There are methodological questions, but we cannot allow people to seize the ground as if they know what they're talking about, when actually we have good evidence-based arguments to counter them. So I think it is go back to what we learned in our public health training and be certain and sure that that is a guide for now as it is for any time.
Thank you, Jim. But this lady in the middle here, and then to Kevin.
Thank you very much. My name is Becky Rice. I'm from Barnardo's. My question is, I think, kind of building on the one previously, as part of how we respond to the cost of living crisis, and as part of how we move the narrative, do we need to challenge the kind of political dogma that some of these more damaging policies are in the name of purely sound financial management?
I think, so being in the NGO space, you have the ability to kind of say, what is more important, the flourishing of our citizens, and with it, the flourishing of our economy, or sound financial management? You heard Michael this morning advance lots of arguments about actually, there are many things in England and the United Kingdom we could do better. So I think it's how you choose to say, if government wants a flourishing society, every government over the last however many years that I know of. So we mustn't make it about political parties. And this is where our strength comes in. We mustn't be partisan. What we must do is push for the highest good. And the highest good, on all the evidence, is human flourishing, because the economy will flourish. And I think if you frame it that way, that is a way to get out of it. Because if you frame it as, you know, sound financial management policy, anyone can come back at you. And you know, new public management, which is where we got, you know, all the audit commission and everything else from. There is value in measuring what taxpayers are paying for, but it shouldn't become a god. It should become a servant to flourishing human beings. And I think it's a case of what is at the top of our values. Am I making sense?
Yes.
That's good. It's not gone off on them.
Thanks, Jim. We've passed the microphone to Kevin, and then we'll move to our next speaker.
Jim, thank you for your 6 markers. Where is the public in this? You look at what's happening in France, for example, where there are riots on the street, engaged communities about, you know, major changes which are happening structurally within their society. Clearly, we have a different cultural norm and expectations. But I still think that there's something here about engaging and educating the public, not only about the impacts of what's happening, but how it affects all of us. And I just wondered, how do we frame that? How do you think about that as part of this work?
I couldn't agree more. And I think it is we have to be going to the people who pay our wages as their servants. So I tend to go to my elected members and what do they want? And to a person, every one of them wants the best for our residents. And then you go to civil society in its various forms. There is no such thing as an unbiased resident or an unbiased civil organisation, because everybody comes from a position of wanting stuff. So I think we do have to do that. I think after COVID, and I think with a range of things that have gone on, we take the trans debate. You're evil if you support trans people, you're evil if you're against trans people. Actually, everybody's shouting and hurting at one another. And in the meantime, people who are trans are being hurt and damaged. And that is unjust. What we need to do is reorient the debate to a place where we can have a meaningful and supportive discussion. So if you're not out round about listening to your residents, you need to be, as a start. And I think as a coalition of national agencies, we could start a national debate.
Thanks, Kevin, and thanks very much, Jim. I think your phrase about communicating more impactfully, Jim, speaks really clearly to that last bit about how to engage the population more generally and to do so as a coalition. Thank you. So now I'd like to welcome to the stage Isabel Braithwaite, who's a Public Health Registrar and National Institute for Health and Care Research Doctoral Fellow. Thank you, Isabel.
Thanks very much, Johnny. And I'd like to thank also Professor Paul Roderick, with whom I've worked jointly on this presentation. So just say I don't have any interest to disclose, and my research is funded by NHR. To zoom out a little bit on our housing system in this country, I'd like to go back to near the start of last century, when it was recognised in the Addison Act that addressing the housing shortage that we had when soldiers returned from World War I was a real priority in terms of meeting those basic needs for housing, and was made a national responsibility, with local authorities given the task of developing new homes and rental accommodation where that was needed by working people. Then we had the Housing Act of 1930, which obliged councils to clear slum housing and rehouse people, with 700,000 new homes built. And when Nye Bevan became a minister, it wasn't actually as Minister for Health, it was as Minister for Health and Housing, which many people don't realise. Housing was a major focus of his work in that period. And then even with the Conservative administration of Harold Macmillan in the 1950s, one of the major kind of planks of his being sort of brought into government was based on the construction of over 300,000 council homes in the previous year. And they continued on that trajectory going forwards. So this is a graph which shows the number of homes built per year since about 1946. And it shows us a couple of things. From the 1940s up to 1980, around the 1980s, local authorities were one of the major home builders in this country. Not only that, but the rate of housing construction per year was roughly double what it has been since the 1980s. So we've kind of had this, this halving of the rate of housing supply since the 1980s. And that's for a number of reasons, which I'll come on to. But not only that, in the same period of time, we've seen the rate of house price growth shoot up since the 1980s, putting that housing supply further and further out of reach as supply has really been outstripped by demand. The same period of time, the private market has become the main source of that new housing growth, but it hasn't increased in keeping with the rise in population from different sources. And that's been despite different types of administration. So previously, both Labour and Conservative governments oversaw that rise in house building by local authorities. It wasn't a partisan issue in those earlier decades. So from the 1980s, we had this really important couple of changes. Deregulation of the housing market, with private tenancies being changed to assured short-hold tenancies. They became much less secure for tenants, and they became much easier for housing to be treated as basically an asset for speculation and for making money from, rather than as homes to meet people's basic needs. So that was one important change. And secondly, right to buy.
Now, for those who may be less familiar with Right to Buy, perhaps younger generations, what Right to Buy essentially did was allowed council homes to be sold off at what's now up to £116,000 cheaper than their market rent in London and £87,000 cheaper than their market rate elsewhere. There's a similar scheme called Right to Acquire for housing association homes. Research from Inside Housing has found that over 40% of those homes are now rented out privately as private rental sector homes, in many cases to the state, for example, as temporary accommodation. This is really, really poor value for money to the taxpayer, as well as creating other issues like disincentivizing the building of new social homes, because it just doesn't make sense for councils to do this and then have them sold off at a loss. Where devolved administrations have had the leadership to end this policy with really quite bad policy, this has paid dividends. So, for example, it was ended in Scotland in 2016, and as a result, they've kept over 15,000 more homes in the social rented sector for future generations in just the first 4 years of that policy. And they delivered over 9 times more social rented homes than England did per capita in that period. This is also shown in this graph of social rented housing per year in the intervening period. And you can see that in almost every year, we lost more homes than were built. At the same time, house prices just increased and increased, putting those homes further out of reach for most people. And this is, of course, quite linked. So essentially, this policy has just led to a net loss of over 1 million social homes to the country, and really been a kind of asset stripping exercise. At the same time, the overall picture in terms of who lives in what type of tenure has shifted. So since about the 90s, after an initial increase in home ownership, what we've seen is peaking in about 2003, and home ownership has decreased, particularly for children since then. So it's now fallen quite significantly. And in the rental sector, we've seen an increase in the private rental sector, particularly for children. It's now over 20%, while the proportion in social rented sector has decreased. So the private rental sector since the 90s and 2000s has been increasing as a proportion of the population overall. And this is important for a number of reasons, which relate to the 4 domains in which housing affects our health. Affordability, which is closely linked to overcrowding, quality, stability and security, and finally homelessness, which is really kind of tip of the iceberg. This is the Health Foundation's classification, but it's related to different classifications that many authors have come up with. How does this all relate to poverty and the cost of living crisis? Some of this is obvious, and much of it Professor Michael Marmot touched on this morning. But housing is a key driver of poverty. You can see this in this graph from the Joseph Rowntree Foundation on the left. A high proportion of households, particularly in rented tenures, are pushed into poverty only after we take their housing costs into account. And housing is one of the largest sources of expenditure for many households, and one of the things that's really difficult for people to modify. A major driver of this is the fact that housing allowances, so housing benefits, have been frozen since early 2020. And so that's one of the reasons why, when housing costs have increased, as they have, for example, in the private rental sector, rapid and quite unprecedented increases since the last couple of years, this is very difficult for people to keep pace with. We know that wages have stagnated relative to inflation. We know that the cost of everything else has gone up, and then benefits have obviously been kind of frozen for many people in this period of time. So this is becoming a really quite untenable situation for many people, and it's pushing a lot of people into debt, arrears, and risk of evictions and repossessions. This is the distribution of housing costs by tenure, and it's a little bit out of date because obviously a lot of the surveys that show us this haven't been published for the last year or so yet. So this situation is probably even worse by now. For the average household in the private rental sector, it's about a quarter of income that's spent on rent, and 40% in London. So you can see that this is really quite a high proportion of income that's going on housing and increasing. So again, that's slightly out of date data. But this private rental sector is hardest hit by this affordability crisis. Again, 2020-21 data there. And so for some households, a minority, this is actually, you know, over 100% of their household income that's spent on renting. And these households are really highly vulnerable and risking going into debt, spending savings, going into arrears, or just not being able to pay those rents and for becoming homeless effectively. Those rents are preventing people from saving, preventing them from being able to think about even the possibility of becoming homeowners. At the same time that since about the early 2000s, the house price to earnings ratio has just been far higher than it was in the preceding decades, so keeping many people out of the option of ever becoming homeowners, as we saw to do with that housing shortage, where it used to be roughly a 4.5 times ratio fairly consistently in the previous decades. Since then, it's been sort of in the 8 or so times average earnings bracket. And this lack of affordability is leading to a steady increase in the proportion of renters in particular that are facing overcrowding, which is driving a range of both physical and mental health impacts, from COVID and TB through to stress, depression, and anxiety. And you may have seen this really awful case in East London, Tower Hamlets, where a man died from a fire in a flat that was housing 20 people in the same room. Tragically, 10 of those 20 people are still homeless, despite protests at the council. And these kinds of situations where vulnerable people are forced to live in extremely overcrowded conditions are extremely widespread. And for people to have those things addressed requires a real systemic structural change, because essentially people don't have the resources to live in less overcrowded accommodation. And so it's addressing that affordability, that poverty crisis that's required to change this. I'm briefly just going to touch on the issue of insulation in cold homes, because Susan has really covered much of this already. But we know that our housing quality in this country is far below the standard that we see in much of the rest of Europe. Our homes lose far more energy, 3 degrees in 5 hours, compared to less than 1 degree in Norway. And this affects health in many ways, both physical and mental, throughout the life course, as Professor Marmot said this morning. We've got damp in over 900,000 homes in the country, and over 650 have an hazard of excess cold. This obviously affects health in many ways, with the kind of heat or eat dilemma and many others. And this is a policy choice. This is not just an accident of our housing stock. You can see this in this graph from the Committee on Climate Change in the bottom corner. You can see the rate of retrofit installations that were done in the bottom left there. The first 3 bars were the number of annual installations of retrofit from 2010 to 2012. And you can see that drop off a cliff that was mentioned this morning when the government decided to stop the Warm Home Scheme and stop funding for these measures, when this government made that policy change. And the greyed out ones to the right are essentially what needs to happen if we want to get back on track in terms of getting our climate change policy to where it really needs to be, and then also the health benefits that would reap. But I'll move on because of time. This is a particular issue in the private rental sector. 23% of private rented homes did not meet the Decent Home Standard, which covers a range of quality and safety issues. And we know that this is an equity issue in relation to both income and ethnic minoritized groups being racially minoritized groups being most exposed. Young people in particular are also highly exposed, and often that's for income related reasons. This was a Resolution Foundation study published a couple of weeks ago. Awab Ishaq, the 2-year-old that died in 2020 due to damp and mold, is obviously something many of you may be aware of in the coroner's report around this. And structural and sort of racial discrimination played a really important role in this. So I think we should be live to the role that plays as well in this crisis, and the fact that both housing associations and private landlords need to really address that kind of racism and discrimination as part of this crisis as well. Just finally, the third dimension of the Housing Foundation's kind of four domains, we know that a lack of housing stability really harms people's health. And this is again worse in the private rented sector. For example, 1 in 5 children, so 20%, have moved 3 or more times by 14, compared to 9% in social rented and 3% in owner-occupied homes. And we know that people's health is rated less good, having moved 3 or more times than if those who did not move. That's with parents. So there's potential hope here in the ending of no-fault evictions, but again, there could be unintended consequences from this. Homelessness, over 250,000 in temporary accommodation, and even more when we take into account rough sleepers and people in hostels. And this seems to be becoming less and less temporary, with over 2/3 of families in temporary accommodation having been there for more than 1 year at present. Temporary accommodation, expensive and very poor quality a lot of the time. And with people being moved from place to place, this obviously has really adverse impacts on both children and adults. And it's large numbers of children that we're talking about. So housing is a human right, and we know that our housing system is broken and really harming people's health. So there's a clear need for public health advocacy on this. Some things that perhaps could help address this and improve the health situation and the poverty impacts that we're seeing from this. A national housing strategy with a focus on social rented housing, because hopefully I've made the case that has a number of benefits, and that this isn't just all about home ownership and the dream that many governments, I think, would like to try and sell, that actually that's not really where we're at in terms of the need, including addressing the harms that right to buy has caused. Well-funded and targeted measures to improve housing energy efficiency at scale, increasing housing benefits that have been frozen, reviewing and strengthening the enforcing regime, linking back to Susan's talk, and funding for evidence-based solutions to and prevention of homelessness. Thank you very much. I'm happy to take any questions. Sorry, I've gone over.
Thank you very much, Isabel. Any questions in the room here or online? Kevin, please go ahead. And there's been a request online that I repeat the question as they can't pick up, if you're happy to.
Well, that was too good not to ask you a question. And first of all, thank you for calling out structural racism and discrimination. We have to say it, we have to name it in order for us to address it. And I'm so pleased you did. Adding to all of this is the asylum migrant seeker crisis that we have, which is placing inordinate pressures around the country on a variety of housing stock as well. And I just wondered to what extent that is also being factored into the work that you're doing in terms of both solutions, policy solutions or recommendations, or how local authorities and local systems should respond to that.
Thanks, Kevin. And for those online, for some reason they didn't pick up on there previously. The question to Isabel around the different policy solutions thinking about, particularly given increasing demands by migrants and others.
So I think this is well, is a complex kind of area, certainly. Yeah, I think the kind of way of trying to approach this that the government have taken in terms of temporary accommodation in hotels clearly has real challenges. It's not an area that I'm very familiar with. I mean, I've had some contact in relation to kind of health protection and things, and I know that a lot of the challenges that different colleagues have had working with this. And I do some work with housing and health group within MedAct, and we've been working with a group in Harrow, many of whom are migrants that live in the block that we've been working with. So I'm familiar, I suppose, with the particular challenges that those people face in getting their rights heard, for be it navigating the system, language barriers, just understanding what their rights are, which is incredibly complex, I think. But I think there's perhaps another perspective, which is that the sort of migration and so on can be used as a narrative of, oh, we have so much pressure on our housing system and so on because of migration. But actually, I saw a really good bit of analysis by Robert Colville, who's a journalist with the Times, which showed that actually really this set of issues would be there irrespective of migration, very much so. And, you know, we obviously need migration and have benefited from migration in terms of economic development and in terms of meeting job needs and all sorts of things. So the point is we should have been planning for and trying to meet housing need in any case, and we've been failing to do that. And then it's a kind of convenient scapegoat, really, I think, and one which is obviously politically very divisive from my perspective. And then we go, well, politicians go and put extremely vulnerable people in extremely inappropriate and unsafe and unhealthy accommodation, like barracks and all sorts of other places full of damp and mold, and where they can't access services and everything else that we've seen, because these are people who are voiceless and can't fight back, essentially. So I think we need to look at the big picture and the real numbers of need, which is in the millions, and it's not about this migration, which is actually quite small numbers. And there was in that same bit of analysis by Robert Colville, he said that if we had had the level of house building that was just the EU average since the 1950s that other European countries have had, we would have 4.3 million more homes than we do today. So I think that's quite a helpful thing for us to kind of remember.
It's really helpful and really clear. Thank you, Isabel. And now I'd like to welcome Philip Satherley, who's Policy and Public Affairs Manager at the Royal Society for Public Health. Thank you, Phil.
Thanks, everyone. As we've heard from the session today and from talking to lots of you over lunch, the cost of living crisis is clearly a huge public health crisis and will have implications for the future unless collective action is taken. It's having an immediate impact on millions of households' ability to heat their homes, provide food, and importantly, access support to live healthier lives. The lasting consequences of this crisis and ongoing poverty will leave a generation in poorer health than their predecessors. This cuts across society, but will be felt unequally and is likely to worsen health inequalities. In addition, and as we're already seeing, cost of living crisis will also have a massive negative impact on economic activity and the financial health of the country. So at the end of 2022, the RSPH published a report based on a nationally representative poll of the UK to start to build up our evidence base on the impact that this crisis is having on our health and well-being. So what this means now and what it could potentially mean in the future. So what for the last decade or so has been affecting the poorest in our society is now an increasing reality for more average households as a toxic mix of increasing prices, debt and wage stagnation takes hold. These are the obvious and visual impacts of the cost of living crisis. But if we look even a little further down the line, we can see that ballooning inflation rates, price rises, rent increases, wage reductions and debt needing to be repaid means that people will stop spending money and slip into poverty. This is particularly damaging as the very people employed in many lower paid jobs are relying on consumer behaviour are those already closest to the poverty line. Once you're in poverty, it's incredibly hard to get out of it. So on to some of the findings of the survey. Whilst this data is from towards the end of last year, it's clear that the story remains the same or has probably worsened. We cover quite a lot in the survey, which you can access on the RSPH website. So I'm just going to focus on a few of the key findings. One of the main findings from our research is that the poverty crisis is now so severe and widespread that households who we might have once considered to have had enough of a financial buffer are now experiencing struggles we might typically associate with those living in poverty. One of the things that stood out is there's a similar percentage of households who have a higher or perhaps quote unquote more comfortable income, and those on lower incomes both indicated that they've used a food bank at least once in the last 2 months. And while we shouldn't take the statistic at face value alone and imply we're all in the same boat, there'll be lots of hidden significant differences, such as how many times have food banks been visited, what were the other needs of the people using the service, or how many items were needed. What it does tell us is that the impacts of this current crisis are cutting across huge swathes of society. And on the right of the slide, you can see a couple of more of the statistics about the impact of the crisis on what we thought of as comfortable income households, or at least those we might have expected to have a financial buffer. What also came across repeatedly in the analysis of this poll data is that there are groups in society who are typically more concerned, making more cutbacks, and have fewer supports to draw on. So when we compared those who are on a low wage, living with a disability, are a parent, or a middle age, there are stark but perhaps not unexpected differences between them and the general public. So in our poll, whilst 39% of the general public were cutting back on fresh food, this compares to 65% of this other group. And 41% of the general public were concerned about the cost of living crisis and what the impact was going to be on their health. This rises to 87% for this other group. Another interesting snapshot from the survey is about parents' experiences. So we found that about 57% were cutting back on essentials for themselves so they can afford them for their children. About a third can't afford all the essentials for their children. Over half reported that their situation is negatively impacting on their well-being. And then just under half indicated that their children are aware of their financial stresses. Mirroring this is a recent survey by Save the Children, which found that about 4 in 10 parents with a household income of 30,000 or less said that their children's mental health had been affected by the UK's economic situation, and many were suffering physical health problems. So to put it crudely, according to our survey, I'd say every other parent, or 1 in 3 parents you pass on the high street, has had to make cutbacks on essentials. And it's no stretch to say that this is going to have a massive impact on their household's health and well-being. So about half of the public feel pessimistic about their household's financial situation over the next 2 years, and 50% felt powerless when thinking about the cost of living crisis. In addition, over 1 in 10 were concerned about affording prescriptions, and 16% were concerned that they wouldn't be able to afford travel costs and medical appointments. And then when you think on a population level, this is having a huge impact. We also asked a question about who should be taking the lead on responding to the crisis. Not surprisingly, the majority said central government, followed by local councils, but interestingly, about a third said employers could be doing more. So a number of recommendations came out of the report, including the need to improve monitoring of the long-term health impacts of the cost of living crisis. One point that we recommended that's really central to the RSPH's work is about supporting the public health workforce, including the wider workforce, so that they can support communities, and also to think about what collective action is needed. So we're all here to share policy and practice, and we have the challenges of funding cuts and a lack of enthusiasm from Westminster around prevention and public health. We also need to be realistic about what money is available for the future, with Labour as yet making no detailed promises around funding public health and prevention. So while we're in a situation where more people are moving into insecure financial terrain, which will have a knock-on impact on their health, and those already living in poverty facing increased impacts on their health, with the inequality gap between the most and least advantaged groups in the UK set to grow wider, and those households who previously could have coped, but can't cope anymore, we can't afford to be on the back foot when responding to the consequences of increasing costs and poverty on health and well-being and inequalities across the UK. Thank you.
Thank you very much, Phil. I think some of those numbers are quite shocking, how widespread already the impacts of the cost of living are, only likely to get worse, and the impacts on physical, mental health, ability to work and child development. Any questions for Phil? Over in the corner there.
Thank you. I'm Paul Wright, one of the fellows of the Faculty of Public Health. I'm just wondering, as we're getting into a stage now where situation with technology it's increasing, and the not threat, but certainly it's going to be a real change to the dynamics of society, maybe very quickly, with AI technologies that may hit, especially that mid to lower ranges in social economics. Have we looked, or do you know if there's anything upcoming in terms of looking at what could happen even further to make it worse, unfortunately,
in terms of, you know, the deprivation, cost of living crisis, etc., so that at least there's some forethought going in preventative wise to maybe changes in society.
Thank you. And for those online, the question around impact potentially of technology and AI, particularly around lower skill jobs, impacts on cost of living in the future. Do we know what that might mean in the future, Phil? all in 30 seconds.
No, I mean, we've had some discussions over lunch about it. You know, I'm hopeful, but things at the moment do feel particularly bad, and we're not going to be able to dismantle capitalism in this room here and rebuild the country. But I know there are other organizations out there thinking about the more positive sides of AI and how it could be used to kind of look at population level health and therefore kind of start predicting what could be done. But in terms of the impacts of AI on the workforce, which I think you're asking, I can't answer that question. I'm sorry, I'm not an expert in the area. I don't know if anyone else in the room is. Sorry about that.
Thanks, Phil. And I certainly think the impact on workforce, so far there hasn't been a huge amount, I think, and in terms of exactly who and what, but tends to have been some really interesting work over the last 20 years of the differences across gender, men and women, ability to transfer across different sectors, that women have tended to be much better than that than men, and particularly in geographies in the Northwest and others where you look at areas where you can pinpoint where it's most likely to impact specific men of middle age, and a specific other socioeconomic factors. So if there is to be a factor, I'm sure it's predictable who will be impacted. And the question is whether we can be preemptive in that.
And I think, you know, there was a point I made about data and monitoring, and I think it's important that us as a public health community come together and share all of that, and we start sharing what emerging data might look like. I'm really interested in what's happening across local authorities to kind of bigger picture Michael Marmot stuff, and I think there's real power in bringing all of that together and unpicking it.
Thanks very much, Phil. We'll now move to our final speaker of the session, Alistair Cooper, who's Policy and Public Policy and Public Affairs Advisor at Barnardo's. Thank you, Alistair.
Hi everyone, my name is Ali Cooper, and yeah, I'm Policy and Public Affairs Advisor leading on child poverty at Barnardo's. So if you've not come across Barnardo's before, we are the UK's largest children's charity, and we reach about 350,000 children every year through our sort of 800 or so services. So yeah, today I'm going to give you just a real quick snapshot. You've had a lot of evidence thrown at you, so I think I'm going to go easy on that and actually just focus a bit on the recommendations in our report. But this is a report I led on, which we published in March this year. And it was essentially sort of looking at what are we seeing in our services about the cost of living crisis and the impact on children and young people. So Michael Marmot touched on this already in his excellent presentation, but we're in a context of rising child poverty, and I just wanted to touch on that a little bit. The latest stats from the Department for Work and Pensions showed that child poverty increased 2% in the sort of most recent statistics that were published. So that's covering up to the financial year ending 2022. And that might not seem a lot, but to give a bit of context, that's the population of Newcastle that we're adding to the child poverty stats. So imagine a city the size of Newcastle, all children, we're adding that number to the child poverty stats. And quite terrifying stuff, really. We're in this period of rising child poverty, and the Resolution Foundation, for example, have done some forecasting on this, expecting it to increase about 3% up to 2024 as well. So a concerning context, and one that at Barnardo's we're very, very worried about. So anyway, in our report, as I said, we focused a bit on what we are seeing in our services in terms of the cost of living crisis. So interviews we did with young people, focus groups with parents and so on. We've also had a big emergency fund, which we've been using to distribute directly to families and young people who need support. So it's providing practical items like fridges that are broken, or food vouchers, money to top up gas and electricity meters. It's sort of direct support. So we've included some analysis there. And then also we've got a survey of 316 young people that we supported. And then the last thing I'm going to focus on very quickly is the polling of 1,000 parents that we did, and that's with YouGov. It's a representative group of 1,000 parents, and we did that in October and also in February. So we were trying to see what issues parents were getting concerned about in relation to the cost of living crisis. So see, these are some of the main stats. The one I'm going to focus on first is actually about rent arrears and debt, and it's something that we're quite worried about. A lot of parents that we work with have managed to sort of squeak by this winter, but to do so, they have taken on a lot of debt and gone into arrears, built up a lot of debt, and I think we're going to see a lot of that really beginning to bite this financial year. So yeah, 1 in 7 parents said they'd fallen behind or gone into their overdraft, and that was a slight increase from October 2022. I think that the broadly interesting thing that came out of our polling that we did both in October and in February was that parents remained as concerned as they were in October as they were in February. So even though the sort of media focus on cost of living might be waning a little, parents are remaining as concerned about it as they were when the sort of noise was really starting to grow back in October. So in the report, I've got a chapter which covers the health concerns about the cost of living crisis and its impact on children and young people, but I've just pulled out a few snapshots to hone in on, which I thought you might be interested in. The first of these is about hunger. And on the previous slide, there was that statistic, 1 in 4 parents said they were struggling to provide sufficient food for their child. That was up 3% from October. And 1 in 20 parents said that they'd visited a food bank in the last 4 months. We just think these are very, very high. And we're also seeing it in our services. We see parents coming in who they've not fed themselves. They've managed to feed their kids, but they've not fed themselves, and they're resorting to eating just the leftovers that the kids left on the plate, and that's it. So I think hunger is something we're very worried about. Secondly, essential items. We've been seeing quite a lot of this, and I think it goes back to what the Trussell Trust were highlighting, really, that gap in terms of getting the essentials. It also means that there's nothing to set aside for if something important breaks down. So if your washing machine breaks down, or in this example, beds and bedding. For some reason, this came up a lot in the interviews that we did, and also we asked some questions in the polling, which were quite surprising. But essentially, there's no set aside income to pay for an expensive item like a new mattress when that's broken for a child. So yeah, on this, the bedding stats, 1 in 7 parents told us that their child has had to share a bed with them or their sibling because they can't afford another bed, and 1 in 14 said that was happening right now. And 1 in 10 parents said that their child does not have appropriate bedding as well. So yeah, a bit of a concerning issue around that, and obviously has an impact on sleep. But I think is a wider illustration of the point that there isn't that income for families to sort of really safeguard if they need to replace an important bit of furniture or an appliance in the house, that they really need to function properly. So housing has been talked about quite a lot already, so I won't go into that in much detail, but yeah, we are seeing very similar things there. A lot of practitioners have been telling me about just parents being unable to keep their house warm and being very worried about that for their child. So lastly, mental and physical health. In terms of mental health, the big thing that we see in our services is sort of stressed parents, and the rising bills, I think, have been the thing that pushed people over the edge, really. So we're seeing lots of worried young parents who are just saying, you know, I just can't cope anymore. These new bills are just really pushing me over the edge. Importantly, kids are picking up on that as well. So yeah, 1 in 3 parents in our polling said that their child's mental health had worsened because of the cost of living crisis. And that was up 3% from October. And then lastly, I wanted to touch on physical health. So one of the interviews I did in the research, I think illustrates this really well. This is from one of our services in Inverclyde near Glasgow. And they had been supporting a dad who was just struggling to make his budget meet every month. And the one thing that the Barnardo's practitioners could see that could be cut or saved really in his budget, the only thing they could see that could be saved was their son's swimming lessons. And I think that tells the story of the long-term impact of what's happening right now, in terms of the sort of opportunity for that child, the physical activity that child gets, the sort of socialization that child would benefit from in terms of the swimming lessons. So anyway, a bit of an illustration of what's in the report, but do dig into the findings if you're interested. So in terms of the recommendations, the report covers recommendations Scotland, Wales, Northern Ireland, and to the UK government as well. The 4 things I've pulled out on this today are a need for targeted action on child poverty. I think the ambition and the narrative and the sort of discussion about child poverty has largely evaporated from public discourse and government discourse in the last decade. And we would want to see an ambition and a sort of strategy and a vision for reducing child poverty. The next recommendation is around extending free school meals. In England, we'd love to see free school meals provided to all primary school children. There's different sort of levels across the UK in terms of free school meal provision. But yeah, getting a child a meal every day has a huge impact in terms of their health and their ability to focus, as I'm sure you're all very aware. And lastly, well, two final points. Ending the 2-child limit. The 2-child limit applies, it limits the amount of benefits that a family can get for every 3rd or subsequent child born after April 2017. And it is the biggest policy driver of child poverty in the UK. That is an easy fix that could be easily changed and would have an immediate impact on child poverty. And then the last one is about extending mental health support teams to every school. So my colleague Becky in the audience has done a wonderful report about the impact and benefits of mental health support teams in school. And that's something that we would really like to see, because kids and parents are worried about the impact of the cost of living crisis, and we think that would help. So yeah, that's all I wanted to cover today. I'll take any questions, but finally, just to note, we've got a health team at Barnardo's as well, includes some clinicians. So we've got sort of in-house expertise, and we're always interested and willing to speak to people as well. So yeah, do get in touch if you're interested about any of our work.
Thank you very much, Ali. And I think those quotes really brought that human element and lived experience aspect to those pretty concerning statistics. Thanks, Ali. Any questions for Ali in the audience before we move to next agenda? Tim.
So my question, thank you for that. Really moving actually to hear that. And I think my question is just about any evidence you have on the impact of cost of living on children's education. So you talked about the kind of long-term impacts these things have, and I do some work voluntarily with a children's charity and hear really sad stories about children turning up to school hungry and unable to concentrate as a result. And that's just anecdotal, but anything you have on that would be really interesting.
Yeah, we don't actually have particularly much on that specific point about education and attainment. I know that there is some work being done at the University of Essex, I think, about free school meals and the impact on obesity and like cognitive development and attainment as well. But yeah, I'm not particularly close to that, but I'd happily take your contact details afterwards and have a chat and see if I can find something. Yeah, I'll go for it. Right.
We have conducted surveys with parents and children around their mental health and the impacts, and 2/3 of parents who had a child with a low or moderate mental health condition were really concerned about the impact that had on their school attainment. So I think that really kind of clear link between the cost of living crisis, mental and physical health and well-being, and that then translating into attainment may well come out over the next couple of years. And teachers and schools are attempting to act as healthcare professionals to catch up on COVID, to, with the same budget limitations that everyone else has. So I think there'll definitely be something in that, but pulling out exactly what that looks like, considering the number and the complexity of the pressures on schools, will be quite difficult.
Thank you for that. Super. If you could all join me, please, in thanking our excellent speakers for last session. I think we're now moving to the voting page. I'll hand over.
Shall we shut them off?
So, yeah.
Yes.
This will literally take us 1 minute. Okay, we've got 15 minutes for this, but we don't end it. Yeah. Hi everyone. Just to take advantage of all you while you're all in the room, or there's people watching us online. What we've been thinking about is what we can do next after today, what we might want to do collectively in terms of kind of policy campaigning, if we wanted to develop a consensus statement. So what we've come up with is a list of 10 statements which kind of would perhaps form a particular policy position or a campaign or something that we all might want to work on together. And to make sure it's not, you know, me, policy person behind a desk just going that one, we really want to hear from you. We've set up a series of statements for people to kind of rank from 1 to 10, and that will inform our discussions going forward. So over to Paul.
Thanks very much, Bill. Just to reflect a little bit where they came from, because we're really keen to get your views. So we've heard today about poverty. It's not new. It's been with us for many decades or forever. It's having a massive impact on our health, killing people. It means people can't get essentials, never mind social and recreational things. Child poverty is really high. No child deserves to be in poverty. It's having massive pressures on our stretched services and on economic activity. We've heard about solutions. We've had national, local, NHS charity, which do tend to be, they're great stuff, but they're largely about mitigation and alleviation. So we thought, looking upstream at preventing poverty, you need to think, why are people poor? Because the money coming in from wages and benefits and savings is not enough for the outgoings, which is housing, food, energy, transport. It reflects the distribution, as Michael said, about our assets and wealth in our society and our tax system, but also discrimination, whether it's racism, sexism, or ableism. So we've come up with these 10 statements, trying to address those upstream things. They're not comprehensive, and you may disagree or agree with them and want to add more. But I hope it will guide our thinking and our priorities. It might help us drive a consensus statement. We've left out things that we think we would all think, in this room, we'd all think more funding for local authorities, more funding for local authority public health, more prevention by NHS, primary and secondary, we're all taken as givens. They're not in. So here are 10, and I'll hand over to Nicola to tell you how you can tell us your views.
Yes, I mean, what a fantastic day we've had. I mean, it's just tragic. It's justice. I think we've heard remarkable things about poverty, and it's about justice. So the ideal of the aspiration is that this has been such a fantastic day. We can't let these thoughts go. We've heard the passion. We need to act. Why we're not acting. And I think the aspiration is that we might get a consensus statement going, because there's such knowledge we've heard today. I think it's going to be unashamedly political in the sense of trying to get things changed. And I know that Kevin has spoken very movingly when I've spoken to him about the need to get politicians involved. We want a very good consensus statement, aspirational, which is going to be fact-based, calm, professional, the facts, the need to get justice. And this is just a kind of, as we've said, just an idea, some of the main things, just to get a ranking, to get an idea of where you professionals think we are. People already started to vote. The idea is that we will get back to people participating, also people online, and that we want to carry forward the debate and keep the drive going and get some kind of statement out that can be used as to support people like Kevin's activities as a calling card. It seems that people are already voting, are probably already familiar. I think we're going to try and keep the vote alive throughout the break. I'm talking to my lovely tech friend at the back for another half hour, because why not? They seem to have disappeared. Perhaps we can scroll up. Can you see them on a line? Anyway, so I think nothing more to be said. I think we'll leave it open the vote throughout the coffee break, because some people can do it fast, some people would like to, and we would love people online. Please, everybody vote. It's something we will be using. We're hoping to report at the end of the day on the findings if it works, because our tech people are fantastic. I think there's nothing else to be said except we want this feedback to really be useful, to carry on as constructed to date, to get justice. Thank you very much for your attention.
So colleagues, we're a few minutes over the timetable, but our time has been well spent. There'll be time for voting. And I suggest now we have a 10-minute comfort break and we rejoin at 3:20. Thank you.
Right, we're just waiting on Catherine.
Good afternoon, colleagues, and welcome back. Welcome back to everyone in our face-to-face audience, and welcome back to our colleagues online. Lovely again to have you with us, and this will be our final panel session before I pass over to Kevin to do the summary and close up with our partner colleagues. So for this session, we're going to have a really fantastic opportunity to ask questions. And we've had great discussions and debates today, and I'm sure there's lots of burning questions, both from our colleagues online and from those of you in the room. But I'd like to start, first of all, by asking the panel to introduce themselves. So, Amika, if I could go first with you.
Hello, everyone. My name is Amika. I'm a first-year PhD student at Cambridge doing a PhD in cancer research. So I'm a clinical research fellow based there.
Thank you. And do feel free to say a few words, panel members, about your interest in health inequalities and poverty and the cost of living. So, Amika, I'll give you that opportunity.
No problem. Thank you. Okay. Hello, everyone. So I've been a member of the Public Health Council at the RSM for a few years, but my research focus is now on cancer at the molecular biology level. So I thought I'd make a very small contribution by highlighting some findings about the impact of the cost of living crisis on cancer patients. And this is by no means the whole story. So firstly, there are a few reasons why cancer patients are at increased risk of financial difficulty in this crisis. One is that many cancer patients need to stop working or reduce their hours because of their disease and the treatment thereof. And this can also apply to their carers, which only compounds this financial situation. Two is that cancer patients have additional costs to bear, such as the transport to and from their frequent appointments, and for those who drive, hospital parking. Macmillan research shows that 83% of cancer patients in the UK experience some kind of financial difficulty following their diagnosis. For those affected, this can reach an average of £891 a month on top of their usual expenditure. And cancer patients and their caregivers in high-income countries, as shown in a separate study, already spend more than 15% of their income on cancer-related out-of-pocket expenditures. And secondly, we have to consider what effect this can have on their treatment outcomes. I'm sure you can see where I'm going with this. Since December 2021, nearly a quarter of people with cancer in the UK have had to cut their costs by either buying less food or making fewer warm meals. 32% of patients with cancer have resorted to wearing coats or dressing gowns indoors to stay warm without spending more. And 1 in 6 have been washing their clothes or bedding less or not at all. Now, this is clearly detrimental, as good nutrition, warmth, and hygiene are essential to aiding recovery. Another worrying statistic by a survey by Macmillan Cancer Support found that 22% of cancer patients were spending more time in bed to stay warm, which immediately rings alarm bells for potentially increased risk of venous thromboembolism, to which patients with cancer are already more vulnerable to. A separate survey of cancer patients showed that nearly half said that they were considering stopping their treatment early, and almost 70 are considering returning to work earlier than advised. Collectively, all of this puts patients with cancer at increased risk of poorer outcomes. A third point that I'd like to mention is that those diagnosed with cancer are entitled to personal independent payments from the government. However, again, research by Macmillan has shown that patients who are able to claim this have had significant delays in getting these payments for up to 22 weeks. Again, this is just unacceptable. So that's just a very quick summary of some of the issues faced, and again, it's not the whole story. In terms of solutions, well, it goes without saying, firstly, that a rising tide lifts all ships, and that what we need firstly is intervention at the national level to directly mitigate the effects of the cost of living crisis. And then the systems in place, for example, with such payments, need to be optimized so that patients who receive these payments can receive them actually in a timely manner. Thank you.
Thank you very much.
Stay here. Any questions?
If you'd like, we're going to do questions as a panel, Amika, so apologies if I didn't make that clear, but lovely to have you with us. Thank you so much. I'd now like, we've met Jim already today, but Jim, over to you if you'd like to probably reintroduce yourself, because we may well have other people joining online, and just say a few words for us.
Do you want me to use the?
No, I think we could sit here.
Lovely,
Okay.
that's great. Well, hello, you haven't heard from me at all today. My name's Jim. I'm president of ADPH, which is the body that represents the professional voice of directors of public health across the United Kingdom and also the Crown dependencies. And my day job is director of public health for Hertfordshire, and outside work I'm a trustee of several places, and was quite struck by what you said, because having had cancer, and I can remember the cost, but I can also, as someone who's a trustee of a hospice, we have something like 2,000 people being cared for in the community. If you're not in a hospice bed and getting fed, and you're in cold weather, that really hit home. The reason I do what I do is because I want to make a better world. And because I think such skill and talent as I have is best directed in that public health world. So for me, tackling poverty is at the root of a flourishing society. I've said enough, I'll stop there.
Excellent, thank you. Thank you so much, Jim. We're now going to go to Dr. Catherine Guy, who's online. Catherine, welcome.
Hi, so I'm Catherine Guy. I'm a public health registrar currently based in the northeast in Hartlepool, and I became interested when the poverty SIG was set up for the RSPH poverty SIG, and I found that as a good opportunity to see what we can do nationally, but also the collective knowledge of everyone there is quite useful for when we're looking locally at what can we do in Hartlepool to reduce poverty, and what our unique role as well, because there are other people within the council who poverty's been their day job for decades, but public health can be a really useful in for saying why it's important, that poverty cuts people's lives short, it affects a child's health for the whole of the rest of their life. So I think we can be very useful in driving things forward and making a difference. But there is a lot to learn about it as well, because we not come at it from the health inequalities angle, but there's a lot to learn about when we're talking about principles like making sure we're not stigmatizing people, how exactly you do that, the kind of looking then for the evidence behind cash first and other policy ideas is something that it's something we need to do. And I think also when we're doing the public health, we're good at doing the science of public health, but this is an opportunity for looking at advocacy and the art of public health as well. So I've been helping the FPH poverty SIG with looking at how poverty affects health and then what we can do about it. Can we act further upstream to prevent poverty from happening in the first place or get people out faster? What can we do to prevent poverty affecting the next generation of children as well?
Excellent points, Catherine, and particularly important given the timeline that Michael talked to us about this morning about how children born today, the effect of their lives going forward. And if I could now ask Johnny to introduce himself and say a few words.
Thank you very much, Maggie. Great to be with you all this afternoon. I'm Johnny Pearson-Stuttard. So I'm chair of the Royal Society for Public Health. In the day job, so I'm an epidemiologist, diabetes epidemiologist at Imperial College London. I lead a health analytics team at LCP, which is an actuarial analytics firm. And then I'm a public health consultant, where a day a week I chair a health inequalities programme board up in Northumbria with a couple of colleagues who are here as well today. The Health Inequalities Programme Board that we set up in Northumbria 2 years ago was deliberately set in the trust because we felt that often, clearly despite a lot of great work within the NHS, often inequalities are seen as an issue for public health out there to be brought out. So the Inequalities Programme Board is very, very much cross-departmental. It has exec sponsorship from the trust, but on the programme board are our local authority colleagues, what was CCG colleagues, PCN and so forth, and with three main aims. The first is to embed measuring of inequalities, to make quantifying them and tracking them usual course of business, and to do that alongside every other business metric that's reported in the trust. The second is to start pilots where we think inequalities are greatest, see if we can do something about it and measure, does it work? And Alison Gowling in the audience here has led some of our work on colposcopy, which gynecology across the trust had the highest level of DNA do not attend rates, and it was even higher in colposcopy, particularly in most deprived young women, particularly in some of the rural areas. Real mix of reasons around that. Some of them were around access, and clearly cost of living might be making that worse. It's great work that Alison and the team are doing to tackle that. The other areas that we work on particularly is the community promise, which is, as a trust, our CSR programme, which has the breadth of the reach across Northumbria, working with our local assets, local colleagues and third sector colleagues to really tap into areas where, because of the trust's really quite unique reach across the region and the size of an employer, see how we can really address some of those more social determinants of health as a trust and play our part. Final part to touch on from my perspective, this is a lot of the work around health and prosperity, clearly very much linked from cost of living right the way through, that it's not just the right thing to do, but this is the economically sensible thing to do, and it's the only really choice that we'll have if we don't act pretty soon. So in a range of range of areas of work across health and prosperity, and Chris, I'm sure, will speak to the Health and Prosperity Commission that he's leading, but particularly looking at the vast inequalities we see in life expectancy, the 21 years for women, 27 years for men, difference between MSOAs in northern urban areas, for example, Leeds for women, Blackpool for men, with those lowest life expectancies compared to those in London. And seeing that those life expectancies have actually gone backwards in those northern urban areas. And then it's even worse when you look at healthy life expectancy. So a lot of our work is really drilling into what's driving that, how that's impacting the ability to work and the longevity whilst in work. And clearly, again, how that impacts broader economic outcomes and inequalities with that. So really looking forward to the discussion.
Excellent, thank you. And just before I bring in Chris, I'll give another reminder to the audience online, if they have any questions for the panel, to start writing now. So Chris, warm welcome, and if you'd like to carry on with your introduction, thank you.
Thank you. Hi, everyone. My name is Chris. I'm head of the Commission on Health and Prosperity at the Institute for Public Policy Research. For those that don't know IPPR, we're the country's leading progressive think tank with offices across the UK and sister organisations like North and IPPR Scotland as well. So I'd like to think we truly do span out rather than solely sit in London. And I'll say just a few quick words about the Commission on Health and Prosperity, which is an initiative which has been set up as an independent cross-party programme running for 2 years to test one hypothesis and then the policy implications that flow from it. And that hypothesis is that a fairer country is a healthier one, but then in turn that a healthier country is a more prosperous one. And so that implies a kind of virtuous cycle between getting policy action on inequality right, but in turn that being good for the economy and that creating conditions in which we can do the right thing as well. Very recently, and I'll just very quickly describe this, we released the first interim paper of that commission about 2 weeks ago. I think it's available online, which bore out a lot of those hypotheses. So showed after tracing people for around 7 years that if they experienced the onset of illness, whether that was a physical or a mental health condition, multiple conditions, whatever it might be, that had hugely damaging impacts on their earned income at the time that we had, as we're talking about today, cost of living crisis, on their employment prospects and their ability to stay in work at a time that we have big labour market challenges as a country. And those things, of course, translate into difficulties around things like growth as well. So ultimately, that health is the medicine that the economy needs at the moment at a time that it desperately needs it, as much as equality is the medicine that health needs. I'll leave it there, but we can go into the detail of it in the Q&A.
Thank you very, very much indeed. So I'd like to start, first of all, with one of the questions that have come in from our audience online. And this is from Brem, a community volunteer. I think it's a really interesting question from the panel because it does focus on what we're going to do in the future. So if panel members could imagine in 12 months' time, BREM works with people from the traveller Roma community. What positive changes could that community expect to see? And Catherine, just to make sure that I don't miss you out from time to time, can I go to you first? You've already talked about some of the changes that you're trying to engage with in the community. Would you be able to give us the first response to that question, please?
Well, I think a lot of it depends on not just us, but the people around us and obviously events and partners. But I think one of the key things is, I think in Brenna, they also talked in another question about involving the community. So I think that's the first step, is making sure that people are involved from the start. There's no good coming up with a strategy and a plan if it doesn't work for people with lived experience. So I think when we're talking about, from a public health perspective, about we need the evidence, and that's data and research of what works, but we also need to make sure it's going to work for the people on the ground. So I think that would, within 12 months, I think that would be a good goal to start with, is making sure you're involving people in planning the difference and hopefully seeing some quick wins. But the quick wins will depend on what people need. We don't want to assume. Like, for example, I know people often think, oh, we'll just give people cooking lessons because they can't cook and that's why they're not cooking well at home. But if it's that they can't afford the electricity to cook the food, then that's a different problem that we need different solutions for. So I think involving people from the start is key.
Excellent, thank you. Let me go in this order. Chris.
Yeah, it's a fascinating question. And I think the answer depends on whether we think about it theoretically, what could change, or pragmatically, what could change. And I think theoretically, lots. It's always striking to me that we know lots of the answers to challenges of inequality and poor health. We know what works often, always more to research, but lots out there that we could do. But the pragmatic answer that kind of contends with the political realities of the piece is that things are very unlikely to change unless we have the infrastructure through which that change can happen. Something that's been really striking to the analysis of the commission so far is we have every public health policy is the underdog. It's very difficult for it to get implemented. You can see a lot of public health policies in the long grass, or under delay, or being watered down, or announced and then not implemented. And one of the things that leads us to question is, why are we treating health in that way, as opposed to in a more systematic way that we see in agendas like climate change, where there is a long-term aspiration, net zero. We've in the commission called for a similar long-term aspiration. There are mechanisms to break that down into 1 year, 5 year pathways, carbon budgets, what's our equivalent of that infrastructure. And there are institutions that really put politician feet to the fire. So the Climate Change Committee, independent, has a statutory basis. I don't think we have anything quite strong as that in the UK in terms of the engine for change. So not a direct answer, and maybe a little bit of a pessimistic one if it relies on the infrastructure and the government architecture to get change to happen. Yeah, I think the kind of basis is currently wrong in the public health kind of policy process.
Thank you, that's great. And Johnny?
Thank you. I think it's a really, really difficult question. And I'd echo both Catherine and Chris's comments. I guess there's two specific aspects I'd add to that. I'd say where we'll be in a year's time, I sadly agree with much of what Chris says, but that I think we, as the broadest, I mean this in the broadest sense, public health community, and it's important we are as broad as we can be. I think the chance of us moving forward in a year or perhaps 2 years' time is much greater if we're in the solutions game. I think we're very, it's easy to define the problem, and there's an awful lot of those. I do think, political parties of all stripes are looking for solutions in the next 18 months as you come up to election. I think our opportunity is to actually bring these together with experts, and those experts clearly include those with lived experience, actually what some of these solutions could be. I think if we can do that as a broad coalition, then we're much more likely to have a chance of a brighter future than if we're in a year's time just again saying how bad it is, which it absolutely is bad, but we must do both at the same time. The second and final one is, I think, again, on the sort of leveraging work that's already been done, obviously within the NHS inequalities work that Olabi's led so well, the Core 20+5 framework is a framework that very clearly provides a framework to tackle inequalities across certain groups of people and across certain conditions. And again, within those plus groups, so there in terms of travellers communities. So again, I'd sort of urge us to, when we're working in any of these areas, rather than reinvent the wheel, where there has been great progress, to really work on that, build with that, and work with colleagues across the sector, again, rather than to try and do that in silos. And I think if we do that, we'll be in a better place in a year's time.
Excellent. I've seen lots of nods in the audience here, so thank you, Johnny. Bill.
Thank you. We are really blessed in Hertfordshire to have a massive Gypsy, Romanian traveller set of populations, and we'd be even more blessed, I think, as a nation if we listen to what they can teach us and give to us. But we have a public health team member embedded in an organisation called Gypsy and Traveller Empowerment Hertfordshire, Gate Hearts. So I am hoping that our GRT populations have 6 asks of us as the public sector. And the first ask is that we should understand them as populations on their terms, not on our terms. And the second thing, that means we need to demythologise Gypsy and Traveller and Roma populations, particularly around funerals when the fire brigade goes in to put out a fire. And it's not a fire, it's actually a part of the funeral ritual. Sorry, that's a personal bugbear of mine. I think the third thing is we should empower our GRT population to have a clear list of asks of things that we should be doing for them better. So better access to services, make services easier to get, make them safer to get, make them enabling and loving and caring. Start with our health visitors. I mean, I've seen health visitors do amazing things with GRT populations. The fourth thing is we should have a plan for that population that we develop with that population. I think the fifth thing is we then need to advocate to get GRT advocates trained up and into the decision makers to do some policy advocacy. I think we need to do that. And then the sixth thing is we need to understand the gifts that population has to give to us. Things like values about you don't see anybody going hungry, which is a very strong value in many GRT populations. So if we could but pivot in that direction, we have much to gain.
Excellent. Thank you, Jim. And Tamika?
I think James has captured it fantastically, and I agree that the key thing is to, understand what the Roma population want on their terms and keep that at the centre of, pragmatic solution making and move forward from there. Yeah.
Thank you. And before I go to the audience for more questions, I wanted to just let everyone know that the firm has actually come back to us and started from the beginning, which we all agreed with, is know your community and get your community to engage and trust with you, which is the first contribution of a joint strategic needs assessment, which is a classic public health first task, isn't it? So thank you very much. Also, to let everyone know, both in the audience here with us and people online, that yes, you will get all the slides. Several people have asked for slides from the presenters that use slides, particularly Michael's slides this morning. So just to reassure you, we'll make sure that you get all of that with an evaluation form from today's session. So thank you. So Kevin, I thought I saw your hand up. So can I go to you first, please? Do we have a mic? Thank you.
So Kevin, President of the faculty, I've been so inspired today. And I'm also recognizing the breadth of the issue or issues that we're covering. And one of the challenges for us as an organization is where do we put our energies and where are we likely to have the greatest impact, both in the short, medium, and long term? So my question isn't on where to focus, but it is a question about context and the political context within which we're working. And the question is, in this very broad agenda, where do we have common ground between different political parties so that that may provide us with a slight opening for us to push? As I've spoken to colleagues today, I've had colleagues say, oh, let's focus on child poverty, right? And then turn a corner, somebody says, I know what we should be focusing on. We should have that national strategy for poverty. Where is there common ground? What can unite us in the context within which we find ourselves to help to push forward on this agenda?
Thank you, Kevin. Well, we'll hear from the panel now, because I think that's a particularly excellent question. And, you know, one of the lessons I've had to learn in public health is if we get too many voices in public health, all people hear is a rabble. They don't hear the messages. So actually part of today is to bring the whole public health community together, but also with an election coming down the track, you know, I'd say political parties are going to be trying a little bit harder, especially in relation to the election last week. So great opportunity. So can I go to Chris first on this one, and I'll give the panel a chance to respond.
Sure, I think it's an excellent question. So I think health should be the common ground that political parties can meet on. I think the job of public health becomes making the case in a way that they can take that ground. The reason that IPR are focused on health and prosperity is that those are the two issues that, regardless of any other context over the last 5 years, and to be honest, since the 1980s, if you take it back that far, top two issues for the public, time and time again, it's health and it's the economy. Nothing has, no other issue has the same stability. And it's kind of interesting, isn't it? Because we often try to talk about the case for health through other issues, but actually we have a really powerful agenda in front of us. In terms of linking those agendas in a way that both parties can get behind, I think there are huge opportunities if we take the parties where they are at the moment. Both parties, of course, about going to growth, and there is no shortage of evidence out there that health and health quality as well can be particularly powerful engines for growth. Both parties, as they currently stand, seem very interested in business as a constituency. And I think it's telling that since the COVID-19 pandemic, both industry groups and businesses have been putting a lot more stock in health and prioritizing it. And I think there's something about potentially the power of that to vocalize it in a way that political parties find attractive. And there's things like the labour market. I think it was remarkable in many ways that we've had a budget that we had a chancellor stand up and talk about healthy growth as its own kind of agenda, and then deliver a kind of back to work budget that had not necessarily all the policies I'd agree on, but kind of uniquely health located as an economic policy lever rather than as a social one. And I think there's probably an opportunity there to push forward. The last thing I wanted to say is just that there are coalitions, then those things represent things that political parties might both want that, you know, if we talk about, we can probably appeal to both major UK parties. The last thing I want to mention is just coalitions within political parties. And I think this is understated, but I think one of the things that is sometimes challenging for public health, particularly when we're thinking about issues like poverty, is that the coalitions that we have of politicians who care about that, you can see why that matters to the issue that they're held accountable to or want to solve, are often relatively small. And so I think if we want to talk about getting to a critical mass within whatever party is in government now, you know, 5 years from now, we need to be better at creating and making and framing health as a solution to the things that other policymakers care about, whether that's by using prosperity as we are, which is about bringing in economic decision makers so they can see their own vested interest, or showing how good health can be the solution to other challenges that we face. Because otherwise we're left with, you know, a relatively junior minister as our only advocate, and that's not how policy gets made. Yeah, some scattered reflections.
Thank you, Chris. I was agreeing with you wholeheartedly in everything you said there. Now let me go to Catherine next, if I may.
Yeah, so I agree, like health is a good in and across the board. And I think particularly they mentioned in some of the communications toolkits that have come out about talking about poverty or about health, the things that land across all groups are lives being unfairly cut short, and sometimes about geographical inequalities or unfairness. Like people seem to be thinking about their opportunities for health or life, and if you don't have that from the start, so in childhood, that's one of the areas, I think, one of the areas that can be quite important. So that's why we hear a lot about child poverty, because it appeals to a wide variety of people, and it's also where you can have the most impact. So one of the Marmot things is giving every child the best start in life, which we can't do if they don't have the essentials for health, and their parents don't have the essentials for health as well. I guess people will always make the point that everybody deserves to be not in poverty, which is one of the difficulties, but I think because of the effect on the whole of the rest of life of a child and the next generation, that's a particular area that you can put more of the focus, some more the proportional universalism we were talking about, where you focus. And you can also talk about what's worked. So I understand that the pensioner poverty has decreased because of government policy over time. And that's, so we know that policies, as well as having a negative effect, we've heard a lot about today, that sometimes it can have, there are policies we can do that can have a positive impact. So I think that's another important issue to think about. But talking about fairness lands and health, I think one of the difficulties is the word poverty itself can be quite difficult. So even people who are in poverty might not see themselves as in poverty, might see themselves as struggling. But I don't think anyone's come up with a great alternative term. I know people have talked about cost of living or the struggle or things like that. But it's about explaining what we mean by poverty. It's about not having the essentials to live your life and be healthy.
Thank you, Catherine.
And a bit about the relative poverty as well, because it's the difference in inequalities that can make the difference, as Michael Marmot was pointing out. It's not just the extreme poverty, it's the fact that you can't participate in society as well, and go to the birthday parties.
Excellent, thank you. And Johnny, like to respond to that question?
Yeah, thank you, Kevin, for the question. A really good one, and I'd love to hear your thoughts on it as well. So I think the reality is there is common ground. I think often it's in the phrasing, isn't it? Or it's the what's the issue that really matters to that, not just that party, but that individual in front of us. And the two that I think of, and then with a third, which is more tailored to the audience. The first is the NHS, which, as Chris said, health being the top issue. We'd love it if it was good health. I'd suggest it's illness and NHS, which is the top rated issue. But and on that sense, it's the demand pressures, isn't it? It's the cost of the NHS, demand pressures. So how can we make our argument using the evidence to support that? So, for example, if it's in the prevention sphere, which is often seen as not a top tier priority, it's not in the headline. But actually, if we can control someone living with diabetes, living with any chronic disease, if we control them better, not only will they be happier, healthier, more productive, but that's less pressure on the front door of A&E. It also means more beds for your elective recovery programme. That's this government's priority. So I think with all of this, what's our issue? What's their priority? And how do we make that case quite logically? And for either party, any party, all care about the NHS and the cost and the demands that are so difficult. Then on the economy side, both main parties and all political parties actually talk about the economy. And I think what really fills me with some optimism actually is that link between health's role in the economy for all of the wrong reasons in the last couple of years with COVID, but actually is pretty clear. And many in Treasury and in Shadow Treasury all do get the importance of that. What you do about it's much tougher, but I think that case is being made a little bit. And particularly given the moment of, is it the great retirement? No, it's the great sickness. What does that mean? That's a very, very clear, with it, being able to tackle health issues in those who are on short-term or long-term sick. The great thing for a politician about that is you can see impacts on productivity within the 5 years that you're elected. So again, that short versus long-term, even though we all know the biggest impacts will be on the long-term. And the third one is, I think on the inequalities issue, I definitely wouldn't shy away from, irrespective of which party you're speaking to. Again, it's about the framing and which language they use and which language can be most impactful. But some of the really persuasive evidence I've seen actually is that if you think the current Prime Minister has 300 and, well, I'll get the numbers wrong, 50 MPs that in many ways the Prime Minister reports to. Now, each of those MPs represents constituencies which have very long waiting lists, which have lots of cost of living pressures, but it's extremely variable. Those that have those, none of them want to represent the areas that have the highest impacts on highest poverty rates, highest impacts on NHS pressures and so forth, and actually finding allies within each of the parties who get what you're talking about. It's what their constituents are telling them, and you're showing them the data. It's actually a really powerful tool to influence from inside. So a couple of thoughts from me, but very much I think it's an ideas game, and I'm looking forward to hearing other panelists too.
Excellent, thank you. Jim?
Thank you. I mean, I think colleagues nail it. I would love us to have a policy conversation about health that for once doesn't mention the NHS, because it seems that politicians are incapable of actually thinking about health without the NHS, but I fear you're right. And so for me, I think we have a couple of challenges. One is there's been divergence on the panel already. I think it has to be about prosperity as an overarching thing, and the benefits that different things will bring to prosperity of the nation. Because at the end of the day, every politician I've ever met, and I was once in an authority with the official opposition was the British National Party, yeah, so that was interesting. They want prosperity. Everybody wants prosperity. And you can frame that through any lens like the NHS. I do think we have a challenge in that, how do we articulate Michael Marmot in language that makes sense for the different types of conservative political philosophy? Well, for one nation conservatives, it's easy, but how do you articulate Michael Marmot for a libertarian? You know, where it's all about willpower and individualism, I stereotype, but you know, the obesity crisis is not because we've all suddenly lost willpower over the last 30 years, or it might be, I don't think so. So I think with the push to them and push to government comes how do we organise ourselves to face forward? We can't push them without all parties without actually pushing ourselves. That makes sense.
Yes, makes perfect sense. Thank you, Jim. Amika?
Well, I guess different parties will, create policies that tend to appeal to their core groups, and you have to ask them, what does everyone want? And again, what key thing is everyone wants good health. In terms of how we do that, thinking about what people see around them, if we were to try and focus on more preventative measures from, investment in the local community, I think that would not only appeal to everyone, but also give them a sense that, they can see changes that are being given to them through their health. And obviously, the happy, healthy, populace is good for the economy, which again, both parties want. So I think that's a good place to go. Thank you.
Excellent, thank you. And I was really struck, I've got a few questions up now, so I think next time we'll take the question and I'll just go to one panel member if you're okay with that, to spin, and that allows us to get a few more questions in. But I think we can safely say, I believe in this country, that no politician would want a situation for future generations like Brazil, from what we heard from Michael this morning. I think it's about how we bring those rationalised arguments to bear, as Kevin was suggesting. So I'm going to go from this end to that end, and maybe what we'll do, if it's helpful, I'll take a couple of questions, and then that means we can get more people in. Yes, please. If I could go to Nisreen and then the colleague next to her. Thank you.
Thank you so much. Nisreen Alwan, Southampton. Basically, I want to say something around intersectionality, because it's really, really important. Poverty does not exist in isolation. It intersects with other social systems of oppression and disadvantage. So the racism, sexism, ableism, classism, etc. And what we tend to do in public health is we isolate problems. We say this is a problem, poverty is a problem, and we kind of try and ignore or control as much as we can for the other variables. And it doesn't really work, and it's not real life. And because we want to go for the simple message, partly because of that, I think, both in research and practice and policy, we don't really do intersectionality very well in public health. I'd like to hear the panel's reflection on this, because I feel like we have to, and we need to make the first baby steps towards that. Thank you.
So if you can hold that question from Nazreen, and thank you. We'll hold that question. I'll take the next two.
Actually, what Nazreen said leads on to what I was going to say. Jenny Edwards from, I'm chair of the People's Health Trust and a member of the faculty. That I know Sir Michael has said in the past, the gateway by which disadvantage enters our bodies and creates ill health is our mental health and the stress and the strain, which is extraordinary on people from the conditions that they're living through at the moment, the cost of living. Through the trusts, we survey the many different communities that we give grants to, and two things have been sweeping upwards, and one is cost of living and the other is mental health, which went up drastically during COVID and even more as a concern. So we need to combine the things that we've been looking at separately, understandably, and understand it's about the extreme pressures on people that are causing so many of our communities to actually collapse in mental health, sometimes even into suicidal thinking, and really having an impact, as we saw from the Bernardo's presentation, on children's mental health. 26% increase, was it, in 4 months? We have got to get to grips with the stress that these conditions are causing. It's where the social determinants meet our bodies. And I'd like to see that in the work that's coming out of the discussions we've had today and in the statement. And I think it's something that's critical that we've skirted around and hasn't quite come together. And just sort of adding to what Nazreen said, Michael mentioned that he'd added discrimination as one of those later things to the social determinants. And again, we didn't talk about that. Racism, discrimination, ableism. We saw that really hitting people being given DNRs during COVID because they had learning disability. These are things that are costing lives all the time, and we need to take that as seriously as fuel poverty and housing crisis and hunger, because they kill people.
Indeed, and I'll take the gentleman behind and then we'll get a response from one of the panel members. Thank you.
Thank you. Yeah, it's Paul Wright. I actually work in many ways around kind of politicians and political work around the Children's Alliance. And one of the areas we've looked at recently, and we were just talking about politics, is that there's a situation that back in the early 2000s, the Department of Education, as we know it now, was the Department of Children, Families and Education. And it was a way in at least that around the cabinet table, families and children were there. Just recently, there is a children's minister, but it's the 6th one in 6 years, and nobody really knows who it is. It's Claire Coutinho. But very recently, that's now changed to the Under Parliamentary Secretary for Children, Families and Wellbeing. And I was just wondering if the panel thought there's a situation that really, if we are to kind of push that, and as you said as well, not just mentioning the NHS and through the Department of Health, if we had maybe someone we can speak to that is actually a department, again, instead of just education, but Department Children, Families and Education, then we'd have a situation that maybe we can look at and have somewhere in the political sphere that we can get our message to and at that top table.
Excellent, thank you, Paul. So, Chris, there's a few really big items there, but I'll start with you to respond, and then I'll try and bring some more questions in. Thank you.
Brilliant. Some brilliant questions.
Meaty enough for you.
Yeah, I mean, I'll try to link myself to one if I can, but that might be tough because that's what's there. And I wanted to. I'm smart people. I'm infinitely interested in the architecture of government and departments. So your question really piqued my interest, and I suppose it struck me that you could argue it two ways. I think the danger of the and is fresh in my mind from recent Department of Health reorganisations, that the and social care element of it entirely useless. It's not taking social care seriously on account of having someone named and having a minister. So that should be kind of fresh in our minds as a risk. But there are situations, I think, where the kind of structure of government can be really important. I think if we go back to when we made some really good strides forward in public health, but 1950s we had housing and pollution within the Department of Health, social security, big chunks of that until the 1970s. And I think there are probably cases where the lack of having any levers over the things that matter to the health secretary and for those that are directly held accountable to health is quite problematic. So I wonder if there is a case within that government architecture piece for thinking through, if not, how do we kind of reorganize as our only measure, how do we make sure that the right levers, the right accountabilities are there, and that we've got a Secretary of State that actually has the tools to deliver health rather than just kind of go headlong down the NHS. And then very quickly, just because it popped in our research recently, talk about mental health, because I just entirely agree. It came through as, don't want to trade off different types of poor health or sickness against each other. But it was the thing in our study that had the biggest impact on earnings and earned income, a massive impact on employment prospects above and beyond any other condition, any physical health condition, which is probably some statement of how a society we treat it. It's some statement of what access to services support that look like, some statement of how well we're accounting for it in public health. And I think, interestingly, probably some factor of how the way that we've organized our economy is playing into mental health, and how slow things like the health and safety regime that we have has been in catching up to that. I will feel satisfied when we get to the day that we have have you had chronic stress at work that wasn't your fault, call now for a no win, no fee claim, as opposed to falling off a ladder, but we just haven't got there yet. Sorry, I've jumped around the questions, so I'll leave it there.
Well done. Thank you. Thank you. Great questions. And now we'll just move over to this side of the room. So if I could go to Graham there, and then if I go to Adfaith, should be able to squeeze these two in. Thank you.
Graham Wynyard, long time retired public health person. The phrase that keeps coming back to me in the course of this wonderful day is Michael Marmot saying these horrible things we've heard about are conscious policy decisions. Now, that may be true as far as the ministers who took them are concerned, but I'm not convinced. They feel more like swept under the carpet policy decisions as far as public debate's concerned. And my question is, given the scale of investment that's needed in housing, in retrofitting, in raising benefits, can we seriously expect to make progress unless we're really willing to confront the obvious fact that if we want European levels of services, we need to pay European levels of taxes?
Thank you. Thank you, Graham. If we could also hear from Abdi, and then Jim, I'll go to you first.
Easy question then.
I wanted to, hi, my name's Advaith. I'm one of the members of the Public Health Epidemiology Council here at the RSM. I had a couple of questions that tie into both the intersectionality element and also into the trying to get people to do the right thing element. So the first was, I wondered if the panel could comment on whether there were any thoughts on how different people from different racial or ethnic backgrounds experience poverty, and whether there's anything that could be harnessed within certain cultural practices that can help to formulate policies to alleviate it. And the second, and also going back to the last question, so one of the few good things that came out of the COVID pandemic is that we learned that the public has a huge capacity to act in the greater good, even when it can be quite at a detriment at the individual level. How can we harness that towards, for example, getting the public to agree to tax rises when already household bills are being squeezed, in order to, well, create a healthier and more flourishing society in the long term? Thanks.
Thank you.
Oh, gosh, right. Well, I think there is far more altruism in the vast majority of British society than we give them credit for. And the kind of nasty individual snipingness for which some social media platforms seem to be a particular driver does not represent the good and the beauty of our society. So I think we have to tie into that. What does that mean in practice? Well, what it means with economic policy is that we have to get better in public health at formulating coalitions with people where we're not signing statements with 90 organisations all signing them that government could go, well, that's lovely, Ben, or you know, anybody, but actually there's 90 different organisations speaking in. If every single health visitor wrote to their MP, plus every single faculty member and every single DPH wrote to their MP, what difference could we make that way? So I think that's the first thing about articulating what the value is. And I think the public during COVID proved themselves consistently way beyond what government was asking for them. They wanted measures. So I think we need to trust in that. That also brings me on, I think, to the intersectionality. That actually, the challenge we face in public health is being able to articulate things in enough complexity that we do something meaningful, but not paralyze ourselves by doing any old thing or doing nothing. And I think that's the challenge I think we have in public health. We feel it feels like we're a wee bit boffiny. We're boffins, and we need to stop being boffins. My ex-boss used to talk about public health being, you know, he used to think that public health was a bunch of boffins who used to occasionally treat sick people. And he wasn't wrong, actually, in many ways. And from intersectionality, what are the resources? So I look at the parish I go to mass in on Sunday, and I look at the Nigerian families and the Polish families and the Czech families and the Indian Keralan families. And I remember the things from my Scottish working class upbringing of caring for one another, sharing resources around one another, accepting people as they are and where they came from. And actually, if we could but see, the one thing about Britain is that we are enriched by the many gifts many nations and races have brought to us. I think we could do that, but we have to do better intersectionality to learn that.
Thank you, Jim. So sadly, of course, we've run out of time. Can you join me in thanking the panel? And I'd now like to ask Kevin to lead on the closing addresses from the partnership organisations. And I think we're also hoping that we might have the results of our polling that we did earlier in the session today. Thank you.
Would you like to do the polling results first before I close off?
Yes, I think that would be excellent. Thank you.
So, Paul, are you in the room? No. Okay, colleagues, I'll take you through the data. That's my day job, so I might as well get active here. So thank you so much for helping to prioritize this. Part of the challenge that we have, both within the faculty and in the family working on this, the public health family, is where do we place our energies for greatest impact? So your prioritization is really helpful. So just in case you can't see, from the first three, our first, a national strategy for poverty, urgent reform to universal credit, and a national housing strategy. And this feels slightly in a sort of public health safe space, doesn't it? Because we always think the first thing we need to do is to ensure we have a strategy. So I'm pleased to see these here. I think this might be calls to government, but it may also be for us as public health partners to develop our own strategies that say, actually, what is the public health community's approach to poverty? What is our strategic approach to advocacy on universal credit? Or what is our approach in public health to a national housing strategy? So while advocating to government, we need to do some work as well on getting a consistent narrative. The next three are on longer policy term solutions to ensure that we prevent people from going into poverty, accessible childcare, and review of employment practices to reduce insecure work. So I think here we're getting into more individual safety net approaches that can help to safeguard both young people as well as adults, get people back into work, etc. So there's a cluster of interventions there. And then the last 4 go into access to school meals, targeted measures on energy efficiency, health and well-being support to those who are getting to work, and a long-term plan to support the public health workforce. Now, under certain conditions, I would be really disappointed that number 10 was number 10. But I completely agree with the group today that given the poverty agenda, that feels like an appropriate number 10. But if this was a workforce well-being sustainability discussion, it would be different. So I hope that helps in terms of thinking about how we frame. What I'm picking up from this is, what are the big strategic things we need to do? How do we create social safety nets, and where do we focus? And then what are some of the other interventions that we can do to help people to get back on track and support people? So thank you everybody for pulling that together. So as promised, that brings us to almost to the end of the session. And you know, we started on time, and I always promise that if we start on time, we finish a little early. So I'll try to fulfill that promise today. Thank you so much, colleagues, for joining us on the line, as well as for all of you here in the room. What a fantastic day it's been. I've learned, I've engaged, I've met new people, and I'm sure each and every one of you here has done exactly the same as well. And it's wonderful to be able to come together as a family. And you always hear me speak about the public health family, because I believe we are in many ways. It's always great to come together as a family to reflect on our practice, to ask, are we focused on the right things? And are we focused on the right things and doing the right things for impact? And in a rapidly emerging areas such as poverty and the cost of living crisis, it is essential that we touch base with each other to understand where we are at and how we move forward together. The last thing we need in this space is for this to be a cacophony of hundreds of voices pushing in different directions when we have people who are suffering, children who are starving, and people who are dying early because of the situation that we're in. So this, more than any, is a time for us to come together. And this is why this is a priority for us in the faculty. And this is why we're doing it together with other public health bodies, because it is so important that we come together. So today we spoke about a lot of things. You heard everything from data from Michael Marmot, lots of research data. Wonderful to have had our voluntary and community sector colleagues joining us as well. You got the practitioner perspective, many diverse perspectives were in the room and online. And that's really important for helping us to, in a sense, get a sense of the nature of what we're dealing with, but also within that to prioritize as well. And I'm so thankful to colleagues who mentioned the things that weren't mentioned in the room today. Focus on mental health. I had intersectionality on my list as well. I was pleased that structural racism and structural discrimination was mentioned, because that has to be a concurrent and deep foundational theme that runs through our work. And there are many other things that I'm sure we didn't have time to cover today, but that's not the purpose. It wasn't meant to cover everything, but it was meant to focus us, to stimulate us, and to inspire us on to do things differently moving forward. So pulling together just a few things. You got 6 milestones from Jim earlier, so I'm not going to go through his milestones, but there are 5 things which I think I'm leaving with today, which I'll be working with my partners and colleagues on. The first is ensuring that we are clear about the data and the evidence that we have that needs to underpin the advocacy work that we're going to be doing in this space. And as you heard from presenters today, it is not good enough. It is necessary, but it's not sufficient for public health people to have public health data that helps us to do our work. We need to have data that speaks to policymakers, the economists in the Treasury, and ways of framing that data that enable us to land our arguments more effectively. So I think there's going to be an agenda together for us to think about our data and evidence and how we package that to support our arguments. Second, as with all public health work that we do, really understanding what are we going to be prioritizing and what are the programs and interventions we're going to be pushing forward together in the weeks and months ahead. This is a large and wide space, and I do not want us to get lost within it. So I'm going to encourage us to be focused on a few things, to understand it deeply, and to push resolutely as a key part of what we do together. It doesn't mean that we shouldn't have an opinion, a voice on other things, But I think working as part of that coalition of hope means that we can be clear about what we uniquely do as public health partners and where we partner with others to amplify voices which are also working in this space. The third area then is around that partnerships and coalitions. And we heard today that that's going to be a key part of how we succeed in this space. And I will, as the president of the faculty, and I'm sure all of the colleagues who we worked with today, that will be an enduring commitment from us. This makes no sense for any organization to do on its own. It is too large, it is too enduring, it is too persistent, and it's too pervasive for us to be working on our own. And so therefore, where we collaborate and how we collaborate effectively to amplify our voices, to focus our efforts, and to have greater impact, I think as you'll have my support for that as well. Final two things then will be a clear advocacy platform. And my question towards the end about, where is there common ground politically? How do we leverage that common ground? And where might we uniquely position ourselves so we're not boffins? That's a very powerful word, speaking to ourselves. But we understand the drivers for policy change in the 21st century in a post-pandemic world. And we are both relevant in our advocacy asks and focused in our advocacy asks. And that's really going to be an art for us as we move forward and thinking about that platform and how we're consistent in supporting it ahead moving forward. So with that, colleagues, I'm going to pause because I think we've learned a lot, we've done a lot today. Thanks to those of you online for being so proactive, I think in the online chat as well. I'm looking forward to going through that a bit later today. I hope you've all enjoyed the session. It's always a joy to work with the Royal Society of Medicine, the Royal Society of Public Health, the Association of Directors of Public Health, and many others to put on events such as this. This is a part of what we're doing and we're committed to doing in the faculty, but to be able to do it with our partners is incredibly important. So with that, thank you for being present. Thank you for being engaged. Thank you for being passionate. And as you leave here, if you take away one thing today, it is the power of enduring partnerships to tackle some of these wicked problems that we're dealing with. So thank you for being here. And with that, Maggie, I'm going to invite you up as well.
Thank you so much, Kevin, and very grateful to you on behalf of Johnny, Jim and I for summing up. We couldn't have done it better. It was absolutely perfect. So also just to add our thanks to the organising committee. These things, as we said this morning, don't just happen. And there's been a very active group from the Faculty of Public Health, the RSM, the Association of Directors of Public Health. Although I seem to think you did all that yourself, Jim, but probably Ben behind the scenes as well. And also my colleagues at the RSM. The RSM has been very proud to host today, and I'd like to thank the technical staff, the staff who provided our meals, refreshments, and everything that was done today to make it a success, but most of all the audience, because this was done to unite us all against these totally unacceptable, unfair and unjust health inequalities. And we have to remember that in the time back in the early 2000s, when we had different policies, and I'm not in any way political, I've worked with great politicians in all political parties, but remember we did narrow the gap, both in life expectancy and infant mortality. And that tells us we can do it, and we can do it again. And it's those actions that we've all been describing today that we now need to focus on to a scale to actually make a difference. And I think Derek Wanless, I would always go back to Derek Wanless with his wonderful report modelled on diabetes that shows and demonstrates how easy it is from the determinants of health right through to health itself, how we can make a difference to our populations, which I know that's what we all want to do. So thank you all very much for coming. Thank you to everyone online. Thank you to everyone in the room. And we look forward to, you'll get all the slides, you'll have the consensus statement, and Kevin's already made our commitment to take action together into the future. Thank you, everyone. Thank you.